Ms. Ishmael, Dr. Tembe Kwayo, Ms. Chirwa, Ms. Slengwa, Mr. Fanstad, and Mr. Supers. I haven't received any apologies. Thank you, Chair.
Thank you very much. Let me again welcome the Minister. Minister, if you can please greet us this morning and tell us who is
Sorry,
with
Chairperson.
you. Yes.
Sorry, Chairperson. Before we
Honourable
start the meeting, I'd like to raise an issue before we start the meeting, if I may, Chair.
You may, Honourable Wilson.
Thank you, Dr. Jacobs. Dr. Jacobs, and ideally we wouldn't discuss this in this format, but it is an issue that is serious and needs to be raised. And it's with regards to the NHI public hearing. And the fact that we have been requested now to finalize this in a hurry. And this will be required to, put in extra mornings, evenings, and extra Fridays. From the DA's perspective, and I speak on behalf of my colleagues, Honorable Ishmael and Korubi, we won't accept this at the moment. We've just come out of an election. Some of us are still very involved in things revolving around that election. It is a very important term in Parliament in terms of sittings and work that we need to do there as well. I think a lot of people are very tired after the election. We will not be able to do these public hearings, the justice, and give them the attention that they require. We are asking, please, instead of trying to rush this through now, we are happy to come back a week before the opening of Parliament and sit for a week to finalise this. But we do not believe that this time is appropriate now to rush through public hearings that we can't give justice to. I thank you.
Thank you, Honourable Wilson. I see the hand of Honourable Van Staden.
Good morning, Chairperson, Honourable colleagues, Minister, Deputy Ministers. Now, Chairperson, I've taken notice about this request, but you remember when we started with this process 2 years ago, I said this is a very complicated piece of legislation which we cannot dare as a committee to try to rush through it, if you understand what I'm saying. So we must be very, very careful that we as members of Parliament and members of a portfolio committee don't harm the democratic process which need to be going on regarding the NHI bill. Honourable Chairperson, as my colleague has said just now, it has been a long election for all of us. We are all very tired. We are still in a big rush with our programs. That's why the reason I hasn't attended yesterday and why I submitted my apology as well for yesterday. We are very busy at this moment, and our programs are jam-packed for the rest of this term or for this quarter until just before Christmas. I don't think I'm speaking on my own behalf. I don't think I'm going to have a Christmas this year. That's how busy we are. So therefore, Chairperson, I would honourably request you that instead of that we as members of Parliament of this committee try to rush through a program and undermine in that process, in my eyes, the democratic process, that we reconsider and rather reconvene. We can either 2 weeks before the opening of Parliament or a week into the next new year, say in the first week of January, we can restart the process again. That is my plea with you and with this committee. Thank you, Chairperson.
Thank you very much. I note what you are both saying, honourable members. I'm going to rule that we keep this to the end of this meeting. We stay behind for a few minutes. Honourable Gela, I was actually making a ruling on that now. Would you want to?
Chairperson, I want to comment on the issue that has been raised by honourable members. I don't think it will be making a justice to our people of South Africa, because we have already started the process of NHI. We break because of the elections, and elections now are over. So we must continue with the business of Parliament. I understand all of us, we are tired, but we are here to serve the people of South Africa. This is one of important legislation that we must make sure that we continue, we pass it as a Parliament in our term. So I understand, Honourable Wilson, your frustration and also Honorable Philip, but please let's prioritize this matter because it's before us and will be not doing a justice to other presenters because already they have prepared and they are ready to come to us and present. So as African National Congress, we are requesting that let's continue with the business of the portfolio committee so that at least when we close the parliament, already we have achieved some of the goal that we wanted to achieve for this year. I understand your frustration, but I think, Chairperson, we also do this meeting through visual. So at least you have time, at least to rest as portfolio committee members. Please, let's make sure that we continue working together as a team because I know that we are the team that is passionate with the work that we are doing. So I'm pleading with my colleagues that let's continue with the presentation. Time is against us. Thank you very much, Chairperson.
Honorable members, I was going to have this stand out to the end of this meeting. Now I see many more hands up. I'm going to allow the honorable members to raise their points, but I'm still going to, at the end of this period when you had raised your points, I'm still going to propose that we discuss this once we have received the briefing from the minister and the department. So please continue to say what you'd like to say, but I'm still going to suggest that we then continue after you had completed, which is next, Honorable Dr. Tembekwayo, and then Honorable Sukers. I see the two hands of Honorables Wilson and Van Staden still up. I'm not going to give you an opportunity now. I'm going to take the other two hands, and then we will discuss this at the end of our meeting. I think we need more time to be able to attend to this. So Honorable Sukers, Honorable Dr. Tembekwayo.
Thank you, Chairperson. I just feel we cannot discuss our businesses in front of the guests, in the presence of the guests. Let us have the guests presenting, and when they are out of our own Zoom meeting, then we can proceed. We don't have to argue in front of guests here.
Thank
so
you,
I agree with you to say, let's stop this thing. And then at the end, we will be able to can do that. And as the chairperson, you are the only person who can rule. We don't accept other people outside you to can come and tell us about what the ANC is feeling or not here. This is not an ANC committee. It's all of us committee. And we have the right to say anything that we want.
Honorable
You were supposed to tell.
Honorable Gela.
I'm not talking to you. I'm talking to the chairperson. I'm not.
No, you are always negative. You are always negative.
Honorable Gela.
No, whenever you want to rule over everything, man, it's enough of you. We've had enough of you. Thank you. Chair, can you continue?
Yes, thank you. I'm going to take only the comment of Honorable Sukers. I'm not going to take any other hands. I'm asking you very nicely. We will discuss this matter at the end of this meeting once we've had the briefing. So please have some patience with the processes. Honorable Sukers.
Chairperson, I will comply with your ruling, which was that we would discuss it when after the business with the department has completed. So I will reserve my comment to that in order for the meeting to proceed.
Thank you very much. Much appreciated, honorable members. If you can please lower your hands, we will continue. Honorable Minister, can you please introduce your team and let us start with our briefing. I have welcomed you earlier and you're much welcome again. Thank you.
Thank you very much, Honorable Chair. I hope I'm audible. Always have challenged sometime with the network, but I assume that I'm quite well audible. Thank you for this opportunity. Also, as we also welcome my colleague there, Deputy Minister, your former chairperson, Deputy Minister Zomo is with me, and the acting DG. So I'm going to ask the acting DG just to give further in terms of who else from the department is on this platform. Thank you very much, Honorable Chair. Dr. Chris.
Good morning, Chair and members. Morning, Minister, Deputy Minister, and colleagues. So, Chairperson, we have with us on the platform at the moment, and others may come and some may need to leave to other responsibilities, but we have with us Mbulelo Kabuko, who's in our strategic planning section, Dr. Akwana Tulare, who's acting DDG in National Health Insurance, Dr. Barry Kishnasamy, who's the Commissioner at the MBOD, Dr. Kobe Maria, who's in our HR and specifically nursing division, Mr. Hadley Nevatalo, who's the acting CFO, and he'll be co-presenting with me during the course of the morning. Mr. Johannes Gatla, who's well known to you all as our Parliamentary Liaison Officer. Ms. Maggie Ravangani, she's also in Human Resources and has presented here many times. We also have Mr. Rams Morawani, who's our acting DDG in Primary Healthcare, and Ms. Valerie Rennie, who's the DG in Corporate Services. Thank you very much.
Thank you very much. Honorable Chair, I assume that I can proceed just to make my introduction to the annual report. Can I assume that you give me that permission, Honorable Chair?
You are correct, Honorable Minister.
Thank you very much. Thank you very much again, Chair. Greetings to colleagues, honorable members of the Portfolio Committee on Health. We welcome this opportunity to come and present the annual report for the financial year 2020-2021, a very eventful year, as honorable members will be aware. Now, our annual report is premised on the NDP 2030 and also guided by resolutions also from the World Health Organization. But it is also premised on the medium-term strategic framework 2019 to 2024, which aims to achieve, amongst others, major achievements being the life expectancy of South Africans to improve. There was some disturbance there, Honorable Chair. The life expectancy of South Africans to improve in this medium-term strategic framework to an average of just under 67 years, 66.6 years, with a view that by 2030, in terms of the NDP, we should have a life expectancy of 70 years. Number two, that we should achieve a universal health coverage for all South Africans progressively, so that all citizens are protected from catastrophic financial impact when they seek health care through the implementation of the NHI. Furthermore, we are also led by, guided by the decisions of the Presidential Summit, Health Summit, the compact which were signed with various role players. This Health Summit was held in November 2018, and the compacts were signed during the course of 2019. Now, in pursuit of this, we embark on an integrated, improving an integrated national health system, which you should respond to priority challenges, which include dealing with our quadruple burden of disease, which entails communicable diseases, and also such as HIV, AIDS, and TB, also as well as non-communicable diseases, also the improvement of maternal and child health, but also dealing amongst the quadruple burden of disease, the burden of accidents and violence. Now, in this process, during the course of this financial year, as we will be reporting in the context of the MTSF of 2019 to 2024, there has been some achievements, even though there's also been challenges, largely also related to the COVID-19 pandemic. But notwithstanding this, there has been continuous improvement in life expectancy and also a reduction in terms of various mortality trends, which have been attributed to improvement in the maternal health, also child health, which has resulted in a reduction in child mortality and also infant mortality. And in the process, of course, expansion of various services, including for HIV, TB, and rollout of antiretroviral treatment. In the process of this, we continue to want to prepare everything for the implementation of the National Health Insurance, as I've indicated that the goal there is to achieve universal health coverage through the implementation of the NHI. So while awaiting the processing of the bill and hopefully ultimately the approval, the adoption of the bill by Parliament as an act, we have to prepare the ground in terms of making sure that the infrastructure and all the various implementation plans are ready, awaiting the approval of the bill. Now, we know that while this work of improving the quality of health has been ongoing, this is the financial year in which we were descended upon by the COVID-19 pandemic, which was declared by the World Health Organization as a public health emergency of international concern just before the beginning of the financial year 2020-21 on the 30th of January 2020. As they say, the rest is history. As we know what happened, that we had the first wave, has our first case of COVID-19 on the 5th of March 2020. And then, of course, the first wave descended on us. We had to go through various levels of restrictions, of lockdown up to the level 5 lockdown, where everybody had to stay home. And it just during this course of this financial year, therefore, that a lot of disruption happened in terms of various aspects of our programs. A lot of resources had to be diverted to fighting the pandemic. And when we thought we're out of it, as we went through to September, October, the number of infections were now down and the level of restrictions also were reduced. But unknown to us, the second wave was just on the corner. And as we went towards November of 2020, we were descended upon by the second wave, which was even more vicious with the beta variant of the COVID-19, and which devastated, starting in the Eastern Cape, going into the Western Cape, and then the rest of the country, and ultimately engulfed the whole country. So this is the period through which we went in this financial year. We went through this 2 waves of the COVID-19 pandemic, which have therefore pushed us back in terms of a number of programs, as will be indicated as we present our annual report. But at the same time, it's good to also realize that it is also during this financial year that we initiated our first rollout of the vaccination against COVID-19. As honorable members will remember that after quite a lot of struggle to acquire the vaccines, on the 1st of February, we were able to acquire the first consignment of the Oxford AstraZeneca vaccines of just over 1 million, expecting another 500,000. But unfortunately, as we know now, this was the time when the beta variant was very dominant. And as the results of the trials of the AstraZeneca then were reported, it was found that the AstraZeneca vaccine was not very effective against the beta variant. And we quickly had to move on because the trials also were happening of the Johnson & Johnson. We were able to acquire some 500,000 doses of that. And we started with the Sisonke 1, which was the vaccination of the health workers. So this was indeed a very tumultuous financial year, through which the bigger bulk of our fight against COVID-19, emerged. But we're happy to say that notwithstanding this, we have been able to proceed. We've been able to, as the waves have been subsiding, we have been able to recover some ground. in terms of the disruption of normal services, including child immunization, including non-communicable diseases, including elective surgery in many of our health facilities, which had been disrupted by this pandemic. So we concluded the 2021 financial year just at the start of the rollout of the vaccination program. And so we will not go into further parts of that as the rest of that happened in the next financial year. So with that introduction, Honorable Chair, I would, with your permission, want to invite the acting DG, Dr. Nicholas Crisp. As you know, Honorable Chair, we did present to you in September in quite an emergency meeting where, because of other developments in the department, there's a number of instability areas. We have Dr. Nicholas Crisp as the acting DG, and as you would see, as he was also introducing, we do have a number of acting heads within our branches, but we can assure you, as we did when we briefed you at that time, that we're doing everything to make sure all the vacancies, especially substantive vacancies, that they are filled so that we stop having too many acting people. But with that, Honorable Chair, with your permission, I could invite the acting DG to lead us in the substantive presentation. Honorable Chair.
Yes, thank you very much, Honorable Minister. Honorable, Dr. Nicholas Crisp, Acting DG, you're very welcome to continue with the presentation.
Thank you, Chair, and thank you very much, Minister. Just three more of our senior members of staff have joined. So just to recognize, Cornelia Ziziba is the Chief of Staff in the Minister's Office, has also joined us. Dr. Zuki Panini, who's acting DDG in HIV, AIDS, TB, and maternal and child and women's health. And Mr. Foster Mahali, who is our communications and liaison head at the moment, is there, or they've all joined us. So with permission, Chair, thank you. I'm going to share a very long presentation, but what I'll do is just pick up on highlights. So there are over 100 slides in this presentation, and it won't help for us to spend the whole day trying to go through everything. The Honourable Minister has already indicated it was an extremely disruptive year, but we remain responsible for pulling together the activities of the health sector in the country. So this is just a reflection of that very disrupted last financial year. We're still aiming for a long and healthy life for all South Africans, and we're still trying to improve the health status of everybody. So even if we do get disrupted during the course of the year, these are still the health sector's main vision and mandate in the NDP for 2030. Nothing has changed here. There may have been some distractions from our ability to get to some of the services in the period under review, but we will report on which of the targets we were able to meet, notwithstanding the moving of the budget and the lockdown and some of the other things that happened. And just for completeness sake, so that the honourable members can go back to the medium-term strategic framework, the goals that are contained in the document, and the House has got the full printed version of our report. So I will move into just some highlights on the performance information for the period, and then the acting CFO, Mr. Nebatalu, will take over and give you highlights of some of the funding and financing challenges we experienced in the year. So we have 6 programs in the department, and during the past year, we had to redo our APP halfway through the year. So I'm going to very briefly indicate, if you'll see, Chair, at the top of the slide in the header, that these were indicators that were removed from the retabled APP, and it happens in each of the programs. And that was as a result of the COVID coming in and us having to redirect our entire APP halfway through the year. Nonetheless, even amongst those indicators that were removed, we were able to do some reviews of our conditional grants. I will focus just on the column on actual achievements so that the honourable members can follow there. And if there are specific other issues, maybe I can get a pointer up and then I can just point to where I'm referring to. So these were some of the achievements at the time. But after the revision of the APP, there were still some challenges, but in terms of preparing ourselves for a more equitable approach to financing in the sector, the equitable share formula has been revised, well, at least the portion that's to do with health, and that will stand us instead going forward when the equitable shares are allocated. That it takes some time to shift because there's been a realignment of the percentages in the health formula. We also got an unqualified audit opinion for the 2019-20. Mr. Nevatalo will report on this. Of course, we always report the financials, the audit reports on the financials 1 year in arrears, but at least we're able to report on that one. Also in this program, and the actual achievements was the medical legal cases are a big issue for us in the health sector, and we have managed to finalize the development of the legal framework and the plan for dealing with a coherent sector-wide approach to medical legal claims system, and I'm sure we'll report in more detail on this in the coming months. There's also, we tackled a case management system, which is a part of our quality improvement program. We were not able to get all of the provinces implemented during the course of the year, but we did get to 3 of the provinces. So in program 1, we do have a number of outstanding challenges. Our conditional grant framework is being reviewed now during the course of this year. We didn't get to it all in the previous financial year, and we are in the process of rolling out the case management system to all the provinces and not just the 3 that we got to in the year under review. In terms of our institutional responses to the COVID-19 pandemic in program 1, this is, we've had to do big reorganizations of everything, but during the financial year, we were able to pay social media campaign and get a coordinated response going. And in our legal services, we were able to make substantive contributions into the NAT joints, which is where many of the preparatory work and for the decision making has taken place, looking at the evidence for lockdowns and so forth. So in program 1, we had quite a heavy participation in the evaluations of the contents of the Disaster Management Act. Program 2 on national health insurance, besides the fact that, as the honourable members are aware, the big target was for us to get the bill through Parliament, and I think you are more familiar than we are of the challenges that were experienced. But during that year, we did form a comprehensive response to the Portfolio Committee and the NCOP, but the bill has not been completed for very obvious reasons. The National Accreditation Framework for PHC facilities and for general practitioners was to have been published, but took a back burner during the course of the previous financial year. But we did start on the benefits framework. A lot of work has been done on it, but it's not been finalized yet. Also in the national health insurance, a lot of our other achievements were delayed, but the terms of reference for the technical working group on the benefit framework were finalized. A technical working group convened and has done a lot of work on this. One thing that we are very happy about, because it was accelerated due to the COVID period, is our health patient registration system, the HPRS. Where our target was to get 46 million people onto the system. We were able to get 49 million. Now, the reason why that looks so many is because there are people, obviously people die and others are born. People also move in and out of the country. So a larger number of people get registered on the system than the population of the country over time. So the public sector is very well covered at just under 4,000 facilities that are already have the HPRS installed. This is the backbone of the patient exchange system and the databases for the country. The master facility list was started, but it's only been really accelerated because of COVID, and we have found that it's extremely useful because of COVID. As far as the health facilities reporting stock visibility, the SVS system that we use, we have exceeded the targets in most instances except for hospitals, and that was accelerated because of the need to monitor the vaccine distribution and the distribution of some of the other critical stock items that are necessary for the vaccination program. And then, of course, because we were not seeing as many patients physically coming during this period to our clinics, we had to change the way in which we used the chronic medicine distribution system, the CCMDD, and we were able to get more patients collecting their medicines from the CCMDD system than had originally been targeted. So we exceeded the target there. Of course, the big issue, and I won't dwell on this, is because you've just had this discussion and we'll do it after this meeting, is to get the hearings completed so that we can get more certainty of exactly what we're dealing with the NHI going forward. So during the COVID period, besides shifting a lot of budgets, we did not get any new budget allocations for in program 2 for any of the activities that we wanted to do. And much of the NHI activity was moved into getting PPEs in facilities and making sure that the digital systems were working and making sure that medicine availability continued during the course of the pandemic. In terms of our third program, which deals with both communicable and non-communicable diseases, of course, COVID became the main communicable disease, but there are several others that are important, especially in maternal, child, and infant health. And we were targeting a monitoring and reporting system for children, for neonates and babies, small children under 5. And we were not able to achieve that during the year because of the shifting of our emphasis. But nonetheless, the systems to enable this have been sustained. They were just diverted to the COVID response. Also, we had some quality and safety and care issues that we were intending to deal with and the planned target was for us to get to hospitals getting food services quality during the year. Once again, it's not to say the work did not continue, it's just we did not reach our targets during the course of the year. Part of the response to getting messaging to women and families about the care of children and infants. It's done through a series of very specific and targeted radio broadcasts in particular. We were able to exceed the number of radio broadcasts. Clearly, the use of digital technology in this period has been way easier than physical engagement. We were aiming to implement a mass drug administration program for schistosomiasis. That was not possible. That's for bilharzia. But the youth zones, we did manage to get the bulk of them implemented, 652 PHC zones with facilities with youth zones, but we didn't get to our full target in the year. There were, health messaging and promoting, as I indicated, has been easier now during this period because of the vast use of the digital system and because we've diverted a lot of what would have been outreach services to the digital space, that we have exceeded the targets there. Of course, there's always lots of room for improvement, and in this particular space, other than COVID, we've got a lot of catch up to do to get the bilharzia mass drug administration program implemented. Again, here, a lot of the budget was redirected. COVID being a communicable disease meant that we were able to step up a lot of our activities in the communicable diseases space. The engagements with the National Institute of Communicable Diseases and strengthening the reporting capabilities and the institutionalization of the data management systems has been accelerated in this period. And also what we call the DATCOV system, where we report on patients in hospitals and activities in lab results and so forth, has been strengthened. But some of the other activities have been left behind a little bit, and we are picking up now during the course of this year. And you'll see constant references to the laboratory services and the Communicable Diseases Institute. That is an ongoing strengthening relationship that we are busy with now, and it was very strong during this reporting period. In terms of our primary healthcare environment, again, we had to remove some of our APP targets, and so these are they. With a realignment of the budget, it was not possible to get to all of the targets. and we shifted some of them out, and we'll reintroduce them in the coming period. So most of these are everything on this page is what we've had to shift out, and it includes previous aims to get community health workers doing tracing, non-COVID tracing. That's what was designed, but it became COVID tracing during the period under review because of the pandemic. In the primary healthcare environment, there were some actual achievements. We have a quality learning program or a quality improvement program that was just starting in the reporting period. The intention was to get to 350 primary healthcare facilities in the public and the private sector. That was not possible, but we did get to 80 hospitals and 64 primary healthcare facilities, which are clustered around what we call quality learning centers. And the honorable members will be hearing a lot more about this, because this, without getting the quality up, we are not really doing the public any real service. In terms of the ideal clinics, the target was to finish 2,100 primary healthcare facilities, but by the time COVID got hold of us, we'd only got to 1,441. So we haven't done the assessment of everything in our target, and we were not able to do the finalization of the policy on traditional medicines because the Traditional Practitioners Council was not established during the disruptive period. Port health services is a massive area of interest for us and activity during COVID. So there was a target to reach all 9 ports of entry, the major ports of entry for self-assessment for international health regulations. The actual achievement was that we did reach the target, but even exceeded it because so much more activity was concentrated in the port health space. There's a lot of the intention to get the clinic committees implemented started with the guidelines in that year, and we're continuing with both the clinic committees and the hospital boards, where we started with the piloting of the training materials in the year under review. Also in the primary healthcare space, there were some specific targets to have community outreach services instituted. This was accelerated because of COVID-19, and instead of reaching only the 1,250 facilities to have these outreach services, we rapidly expanded it to 2,185 of the facilities. And because of COVID, the community health worker program reached far more than was originally planned as well. Again, some of the targets that were not reached or where the resources were diverted, like the National Quality Improvement Plan, has been picked up again in this year and will become a focal point going forward. I won't dwell on all of these because we have made progress with outreach services and the community health workers. I think you've heard a lot about port health services, in particular, the points of entry and control at harbors, ports, and land borders. This is an ongoing issue. And of course, in the early part, when there were so many new rules and regulations being formulated around the handling of corpses and the mortuaries, this kept this program extremely busy and having to change direction a lot during the pandemic. Also with the screening of travelers, and in the early days, which was part of this financial year with people coming in and needing to go into quarantine, it kept the port health services extremely busy. I won't go into all the details. The primary healthcare system, all our health facilities in the public sector have been involved in one way or another looking after people with COVID infections, massive reorganization of oxygen supply. That has been a particular focus. As we know, this is a respiratory disease, and a lot of respiratory support devices were either built in the country or imported into the country. Refurbishment of hospital beds and ICU beds. I'm sure I don't need to spend much time on this. It's been reported on quite a lot. In the hospital systems, the main focus is in this particular program is in fact on infrastructure. And during the COVID period, we had to fast track a whole lot of the infrastructure programs and divert some, as you're aware, to mass facilities during the period. but it did mean that we have made a massive refurbishment of our oxygen supply and a number of other ICU and ventilation issues in all the hospitals, which was necessary for COVID response. So again, here you'll see that the COVID response dominated because of needing to get the laboratory sorted out and being able to get the laboratory results back to hospitals quickly to enable the clinicians to make the necessary clinical decisions. And we had to move some of our budget to enable that to happen. That affected the ICUs and the general wards and all the facilities. Quarantine and isolation were in the early parts of the pandemic last year were a big challenge for us. We did not have the capacity in the public space and had to get additional bed capacity from a number of other facilities and custom-built facilities for those purposes. Getting to the last program, on program 6, which deals with governance and human resources. We had to remove some of these targets as well because of the shifting of the budget and refocus onto COVID. So the planning and monitoring activities, instead of being more generic, have spent a lot of focus, and the implementation of our information systems has had to shift to the COVID space. Fortunately, none of what has happened in this space has been lost, and we have been able to build a very strong capability in this area. There was supposed to have been a review of the remunerative work policies. This is where doctors and nurses and other health professionals are given permission to do work outside of the public service for their own benefit. That review was, our plans were shifted because of lockdown and the staff not moving around so much anymore. And there were also issues around our employee time management system and biometrics, which was put on hold for the period. The procedure for coding, the framework for the use of diagnostic and procedure coding has been postponed or removed from the APP, but is back on the radar for the coming financial year. We were due to get HIV and TB systems accelerated during the period. And once again, we've put that on hold and removed it from our APP. The system is in place and it's still reporting, but the increase in the capabilities of the system was just put on hold for a while. The performance and dashboards for decision making have, although they're not on the APP, on the revised APP, we've obviously needed those dashboards for decision making in the infectious diseases space for COVID. So we have not lost the capability. It's just the targeting of what we were trying to do, like for instance on blood and alcohol levels, which was going to be a focus in the year, was just deferred. So what did we achieve? We achieved that we continued with the accreditation of the nursing colleges. We didn't get to all of them, but this is obviously critical for the long-term sustainability of our nursing workforce and will be stepped up in the future. The early part of last year, it just wasn't possible to get out and do the accreditation of all of the nursing schools. As far as the governance, clinical governance is concerned, for COVID, this was accelerated, but for all the other clinical governance systems which we had targeted to put in place, it was only really possible to get to one of the major projects. We have a target to continue with equitable staff distribution. Obviously, in the COVID period, we've had to redirect our response where the COVID epidemic was moving. So it moved around at different times between different provinces. So it's not been as targeted, and so we've put it as a null achievement. But the other targets in this area to get the health patient registration system going and the track and trace for COVID, all of this has been achieved actually beyond what we had anticipated, and we're very happy with the progress and the foundation that's created for us going forward. So our information systems were due to be linked to the laboratory services during the course of the financial year. Not all of those facilities that we wanted to link were possible, but the track and trace system is implemented and is functioning between the National Health Laboratory Service and the primary healthcare facilities. And in fact, some of the private facilities, we are also able to link to that. The interoperability norms and standards for the digital systems were finalized during the course of the year and will be gazetted now during the course of this year. And then the national health research priorities were continued, and we were able to reach the targets that we had set for ourselves. So going forward, we do need to engage with the Nursing Council to fast track the nursing colleges, the provincial nursing colleges accreditation on various programs. We still want to accelerate our HPRN activity and the interface with the laboratory systems, and to finalize the publication of the interoperability norms and standards which have been agreed and formulated and ready to go. So in this area in program 6, in terms of the pandemic, as you can see, it was really about recruiting at short notice doctors and nurses, and you can see this in the immediate outcomes column on the right-hand side, to get larger numbers of staff available to back up both the hospitals and the response in the community outreach programs. So COVID has very much dominated all the activities in this space, all our information systems, and the way in which the information systems are integrated with the laboratories and our ability to report. And that's what I think the honorable members would have seen, all the dashboards and things. It has been possible because of the redirection of the budget here, and we will build on that for all our information systems going forward. And then lastly, in terms of diagnostic and therapeutics and vaccines, our collaboration with SAHPRA has been strengthened. The National Department does not get involved at all in the adjudication or approval of any diagnostics or therapeutics, but we do work very closely with SAHPRA to make sure that when there are priority drugs or interventions, that we bring it to their attention and they accelerate them. So the summary, honorable members, Chair, is that we did not reach all our targets during the year. Only half of the targets were reached. There were a whole lot of targets that were not actually targets in the APP, or activities that were reached. And there's a lot of catch-up that has been started during the course of the year subsequent to 2020 and 2021. In terms of our human resources, the last slide, you've heard from the Honourable Minister that we have a lot of people acting in positions at the moment. We had, during this financial year, at the 31st of March, at the close of the financial year, 1,943 posts, and we had filled 1,394. There has been substantial reorganization of this in the subsequent financial year, which we will report on in the future with this realignment and filling of posts. And at that point, Chair, I'm going to hand over to Mr. Nevatalo to take us through the highlights of the finances of the year. Thank you. I will change slides for him.
Thank you, Acting DG, and good morning to the Honorable Chair, Honorable Members, Honorable Minister, and Honorable Deputy Minister, and the colleagues. Because we have got a lot of slides under financial management, I've prioritized 10 slides. I will speak to the summary per program, which will be slide 56, summary per economic classification, COVID-19 special appropriation, summary per direct grants, summary per province, NHI as the key priority, COVID-19 component, and summary per indirect grants, as well as the audit outcome. I am the acting CFO starting from the month of August. So acting DG, can we move to the next slide? Yes. I just need to give an introduction that the COVID year was one of the most difficult years for us as bookkeepers or financial managers, because in 1 year, we had 3 adjustment budgets. We had the special adjustment budget in June 2020. We had a normal adjustment budget in October, and we had another second special adjustment in January. Hence, when we were doing the books, preparing the books for the audit, there were some misunderstanding between ourselves and National Treasury and AG, but at the end of the day, we did agree. So if you look at it, we had we have got 6 programs, which they were allocated during adjustment, all these 3 adjustments. We had the 58 billion rand, and as a department, we went and spent 57 billion rand, which translates to 99.1%. Then we have put the statutory, the COVID special appropriation. What happened is in January, during the second adjustment budget, the National Treasury sort of reflected that we are going to receive additional 1.2 billion rand for COVID. However, this money was not appropriated through the parliament process. So we had to spend the money without receiving the money. And out of the 1.2, we spent 612 million, which increased our expenditure to 58 billion. Then I need to go back to the programs to say what are the reasons for the variations, either under or overspending. Program 1, which is administration, we underspend, we spend 83%. Reasons are, 1, officials, we were not able to pay officials notches increases for the past 2 years. We were not able to deal with our PMDS for 2019 and 20. And we need to indicate that that issue has been dealt with in this current financial year. The national health insurance, the other issue which was a problem in program 1 was that there was an issue of the rental of the old building that we're occupying, which is called the Civitas building. From September 2020, after we had the floods, we were evacuated from the building. So as a result, we had a dispute with the landlord, which is Public Works, to say we are finding it difficult for us to pay for the building that we are not occupying. And we need to indicate that at that time, as finance people, we had to squatter at National Treasury, at Forensic Lab, together with CETA and numerous departments. And as a result, it was not easy for us to coordinate our activities. And some invoices were not paid on time due to COVID protocols and limited access to financial systems. Program 2, National Health Insurance, we spent 85%. Yes, we underspent because of the COVID protocols and also system issues experienced at the end of financial year. So we had a challenge that towards the end of the financial year, the system went off. The logis and bars, they went off. As a result, there were a number of transactions that we have processed, but they only appear in this new current financial year. Program 3, which is communicable and non-communicable diseases, we spent 99%, which is almost 100, but we underspent because there were few projects that were cancelled due to COVID-19 pandemic. Program 4, primary health care. Here we have overspent. We have overspent by 13.7% due to the overtime payments that were made to the port of entry staff. When COVID started, we find ourselves having challenges that we don't have enough capacity at our port of entry, where people had to leave and come back to the country. So as a result, they had to work abnormal hours, and we had to pay a lot in terms of the committed overtime. Hence, there is an overspending. Hospital services, which is program 5, we spent 99.9%. The underspending was due to low spending on goods and services due to COVID. Program 6, we overspent by 0.2 because of a system issue. What happened was that the system, we had an overpayment on the human resource grant, which was paid to KZN province, and it was about 30 million rand. It was transferred, double payment were made by the system to KZN. However, the challenge was that the money was paid back. We have got the money in the department. The only challenge with us was that it was only paid back in the month of May 2021. So it was not, we were not able to account for it. We were not able to write it off because of that, but we are engaging with the AG and National Treasury. How do we account for that 30 million rand that is sitting with us at NDOH? The next slide, acting DG on economic classification. So here we are showing our adjustment budget in terms of economic classification. If we were to look at the column for COVID-19 special appropriation, we are just showing how this 612 million was spent. We have spent 462 million rand on the procurement of vaccine under program 3. We have transferred 150 million under program 6 to Medical Research Council for COVID researches and Sisonke project. So if you look at all the classification here, is that compensation of employees, we underspend by 1 million because we spend 99.9. Yes, here it's because of the vacant posts that could not be filled and the notches that were not paid, notch increases that were not paid for the past 2 years. The goods and services, I've already spoken to that to say we underspent here. We spent 80.2 due to non-payment, the rental payment of Civitas building, which was withheld. And also there was slow implementation of projects due to lockdown and COVID projects. Transfers, we have transferred all the monies that were supposed to be transferred. And I need to indicate to the committee that the bulk of these transfers, because when you look at the total budget of NDOH, of National Health, 90% of the budget, over 90% of the budget is the transfers of conditional grants to provinces. So these transfers here, the bulk of it is the money that we have transferred to provinces, meaning that we did not withhold any funding. The last one is the capital expenditure, payments for capital expenditure. We underspent due to the slow implementation of projects due to lockdown and COVID-19 protocols. The next slide on COVID special appropriation. I've already spoken to that. I'm not going to talk to the programs. I'll move straight to the conditional grant. Can we move to the conditional grant, ADG? Yeah, can you, yeah. In terms of, you can go to the table itself straight, the next slide. Yeah. Then I will narrate. Yeah, thank you. In terms of the conditional grant, we had an original budget.
Did we lose you, acting CFO? Can the person who is not muted, whose mic is not muted, please do so? Acting CFO, did we lose you?
Can we try and find him? Mr. Khatla, can you try and find Mr. Navitalo?
Yeah, he's
Sorry,
on
I'm
mute.
back, I was muted.
Thank you, thank you.
Thank you. So, thank you. I was saying in terms of the grants, we have got two types of grants. We have got the direct grants and the indirect grants. The direct grants are the grants that we transfer funds to provinces to render services as per DORA frameworks. But when it comes to indirect grants, we as National Health, NDOH, we render services on behalf of the provinces. Hence, I said that the bulk of the money, the 54 billion rand, which was reflected under transfers, 52 billion rand of it is this funding which is here, which we have transferred to the provinces, which hence we have reflected 100% under national transfer, meaning that we never withheld any funding for any provinces. So provinces went and spent 51.2 billion, which translate to 97.4, which is less than 97.4%, which is less than 98.9, which you have spent in the previous year. So if you look at it, all the conditional grants, they underspent. But the major contributor to underspending is the health facility revived grant, which have spent 91.7, which provinces have spent 91.7%. Obviously, there was poor performance of contracts and the effect due to the effect of the COVID-19. If I were to look at NTSD, National Treasury Service Grant, provinces spent 97.2, which is less than 98.8% for the previous year. HIV, TB costs, this is community health workers, malaria, HPV grant. They are combined into components and they have spent 98.1%. However, if you look at HIV and AIDS component, it overspent by 410 million. But the agreement with National Treasury is that because all these components fall into one program, as long as the overall budget for the grant is not overspent, it is not a problem because one grant will underspend whilst the other one overspent. And the results of this overspending is that we had to shift money to try and add some allocation. Provinces were paying for COVID expenses under the COVID component. So we can move to, then the next one is the statutory human resource and HPTG grant, which we have spent 98.3. The last one is the NHI, which I will talk in detail in the next slides, 93.9. Can we then move to summary per province? What we are reflecting here is that we want to reflect how the provinces have spent all the monies that we have transferred to them. If you look at Eastern Cape, they spent 100%. Free State, they underspent with 93.6, depending on the grants, which grants they've spent, underspent. Gauteng, 96%. KwaZulu-Natal, 99%. Limpopo, 94%. Mpumalanga, 100%. And Northern Cape, 99.5%, and Western Cape, 91%. And 100% for Western Cape. So all in all, provinces spend 97.4 and as compared to 98.9 for the previous financial year. The next slide is just reflecting each grant per provinces, which I'm not going to go through. I will move to the National Health Insurance. Acting DG, you skip it. National Health Insurance. There we have it. The National Health Insurance, I'm talking to it because it's a key priority.
National Health Insurance Grant. National Insurance.
Honorable Xiaomai, can you please mute your microphone? Thank you. Please continue.
Thank you, Chair. In terms of the National Health Insurance Grant, we were allocated, originally we had a budget of 288 million. And then during the second adjustment, it was reduced down to 247 million. And we have transferred all this money to provinces, and they have spent 232 million, which means that they underspent by 14.9 million. And the expenditure has increased from 90.4% to 93.9%. There are 3 provinces that have got significant underspending here, which is Free State, GP, and KwaZulu-Natal. So their reasons for underspending was inability to attract general practitioners and the effect of COVID, as some doctors had to withdraw their services. There were no rollovers requests as the funds were not committed and used for personnel. I need to indicate that with the underspending of overall conditional grants, provinces have applied for rollover requests where commitment has been made. Unfortunately, that process relies on provincial treasuries to approve or disapprove. Then we get informed when provinces captures their own adjustment budgets, which they are busy with at the moment. Then we'll move to the Covet component, ADG. The previous slide, the Covet component, this one, thank you. When we started the financial year, we did not have, we only managed to scrap, we only had 604 million rand. Then during the first adjustment in June, we were allocated 2.8 billion. Then second adjustment, it was reduced by 28 million. So we were left with the total adjustment budget was 3.4 billion. And we have transferred everything to the provinces, hence the 100%. So the expenditure provinces went and spent 3.2 billion, which results in underspending of 168 million, and that translates to 95.1%. The major underspending was incurred in Eastern Cape, Limpopo, and Mpumalanga. And this was due to delays in the delivery of equipment and PPEs. However, if you look at KZN, there was an overspending of 74 million. So what we normally tell our provinces is that as NDOH, when it comes to conditional grant spending, we count it up to 100%. Anything above, they need to generalize it back to their equitable share, because it means that they've paid from their own equitable share funding, not from the grant. And that's what KZN was going to do in terms of that overspending. The next slide, DG. This slide is just showing the rollovers that were requested by provinces, and we are still awaiting the outcome that will come from the provincial treasury together with national treasury to say which rollovers are approved and not approved. So at the moment, we haven't received that. Can we move to indirect grants, the one we spent in Pretoria? So in terms of the indirect grants, the total grant here, we have got, it's 1.7 billion, and we have spent 1.5 or 1.6 billion, leaving us with an underspending of 154 million, and we have spent 91%. The major underspending of this grant is on the non-personnel services in terms of CCMDD, together with the medical, together with the patient information systems, medical stock surveillance systems, and this was due to the system that went off towards the end of the financial year. So the payment went through only in April of the current financial. Hence, we are having those underspending. Hence, I said we had an issue with the system, and we are saying that when we account for our books for this new financial year, we should be able to account for this. If you look at infrastructure, the health facility revived grant, we managed to spend 97.7% of the grant, leaving us with an underspending of 21.8. In terms of Limpopo Academy, we spent 78.2 and leading us to an underspending of 47.7. The reason is that, yes, there was delay in the implementation of Limpopo academic hospital projects due to COVID lockdown and due to COVID lockdown and protocols. So on the other hand, I'm saying that the underspending on other items, it was mainly due to offline system of logis towards the end of financial year, and the expenditure, the payment had to go through in the next financial year. The next one is the audit outcome. Here, maybe before we proceed to the two slides, acting DG, the previous two slides. Yeah, this one. So here, what we are just trying to show, sorry, the next slide. Yeah, so what we are just trying to show is the 2021 Mtf allocation. The point that we want to register is that we, as the health sector, national together with provinces, our budget over the Mtf for the next 3 years has been cut by 76 billion rand. So in terms of the direct grants, if you look at it, over a 3-year period, the budget has been reduced by 11.8 billion for the 3 years. So if you look at 1.8 for this current financial year, billion, 3.4 or 3.5 billion, 2022, 23, 24, 6.4. However, we have already engaged National Treasury about this huge cut that they are very massive and they will affect service delivery in the health sector. We had such engagement with National Treasury through the 10 by 10, and we are still engaging on that. On the indirect grant, the next slide, 18TG. We are just indicating that over a 3-year period, starting from this financial year, the budget has been reduced by 411 million, 200 million, and 55 million. So all in all, if you look at it, it's about 668 million rand reduction, and this will affect the service delivery. But as I've said, we're engaging the National Treasury. The audit outcomes, which will be my last slide. The audit outcomes, here we are just reflecting that for the past 10 years, the National Department of Health has been receiving unqualified audit opinion, and it is our, and we can see that we had some significant improvement, and we are targeting to achieve clean audit in the coming audits. However, the next slide. However, here we're just showing the improvement in terms of audits to say that the number of NVCs have been reduced from 2 to 0, and clean audit is within the reach. The next slide. The performance audit, the previous slide. When we are audited on 2 fronts. We are audited in terms of the financials, where we receive the unqualified audits, and we are also audited on performance objectives or performance information. So in this case, we received a qualified audit opinion, and this was based on the number of facilities where the link between HPRS and NHLS track systems are implemented. They were not talking to one another. So for us to achieve a clean audit, it means that we need to achieve both unqualified audit opinion for both the financials together with the performance objectives. The last one is, what are the strategies that we need to pursue to move towards or to achieve a clean audit? Obviously, we are saying that ourselves together with provinces, we have to develop and implement audit improvement plans, and we must report on the progress on identified audit risks as per audit management report monthly, quarterly, and we must also ensure that auditors obtain sufficient appropriate audit evidence relating to informations on systems and process were established to enable consistent measurement and reliable reporting. And the last point, we need to strengthen internal control systems in terms of proper record keepings, proper reconciliations in terms of daily, monthly, and quarterly and annually. So we need to improve that. We need to improve our control and monitoring mechanism. Thank you.
I just wanted to check with the acting CFO. I see on the audit outcomes, we also do usually reflect on progress in provinces. I don't know whether it was deliberate that, although we don't do the actual financial management, but because we support provinces, we often do reflect on progress. So I don't know whether they didn't have a slide on the progress with the audit outcomes for provinces. Can I just check with the acting DG and the acting CFO?
Yeah, thank you.
Yeah, okay, Hadley, thank you. Go ahead.
Yeah, I think we had the slide. It's missing here. We put it it was there, acting DG, on when we presented to NCOP. We had a slide on actual audits for the province, and I can read in front of me. I've got it. I don't know whether you'll be able to draw it, acting DG, to draw it from the presentation we did to NCOP.
Maybe in the meantime, just talk to it.
I'll look for it if you talk. Thank you.
Okay, thank you. What we have is that the slide, we were reflecting the 10-year audit outcome for provinces, and over a 10-year period, only Western Cape and NDOH received unqualified audit opinions. By 10 years, we included even the audits for 2020-21. So Gauteng, for the past 6 years, they also have been receiving unqualified audit opinion. So yeah, here's the slide. Thank you. I was saying that if you look at the slide, the Western Cape has been receiving, and National Health, we have received unqualified audit opinion for the past 10 years. The reason why I've colored, I don't know what this is, colored gray for 2019 and 20 is that for the annual report for 2020-21, we are referring to 19, 20, and 20. So because we had the results for 2020-21, which will reflect in the annual report for the current financial year, we thought that we need to report about this. So if you look at Gauteng, they have received unqualified audit opinion for the past 6 years, and for the year under review, as reported by the acting DG, we had 4 provinces plus national that received unqualified audit opinion, which was Gauteng, Limpopo, Mpumalanga, Western Cape, and ourselves as NDOH. For the audits outcome that we received from the end of August to September this year, Eastern Cape received qualified, Free State qualified, Gauteng unqualified, KwaZulu-Natal qualified. The reason why we have put Limpopo as red is that the information we received, we gathered from the HOD of Limpopo together with the CFO, is that they were busy disputing this audit outcome between themselves and the provincial AG, because they indicated that during the last audit and risk committee meeting, the provincial AG indicated to them that they have received an unqualified audit opinion. However, 2 to 3 days down the line, the AG then released a report saying that no, the department is now qualified on because of assets. So they've raised a dispute and they've written to the National AG for them to state their case and have a review of their audit outcomes. Mpumalanga, they have managed to maintain the unqualified, and in Northwest, where we have got administration, they have been receiving qualified audit opinion. There's an improvement. They have moved from qualified to unqualified. So Western Cape and NDOH have maintained. So in percentage terms, we have got 50% of the in the health sector achieving unqualified and 50% qualified. However, we are saying for Limpopo is disputed. If we're to get an unqualified opinion, we're going to be sitting at 60%. Thank you.
Thank you very much. That concludes the presentation, Honorable Chair. We hand over back to you.
Thank you very much, Honourable Minister and Acting DG and the Acting CFO. I seem to be using the word acting so much now, Honourable Minister. But yes, we take note of what you said earlier, that you are busy dealing with these challenges. Let me just remind ourselves, before I allow the members to raise any questions, of the often quoted statement that the health of a nation is indeed its wealth. So that it's important for us to interrogate this presentation very well. And to be reminded also that investment in the health system of a country improves the health outcomes and saves lives of those who are sick. And then also the State of the Nation address when the President of February 2020, when the President recognized health as a fundamental condition for growth and development. And also that he recognized that South Africa is still struggling under the quadruple burden of disease, and he was very excited about the support for the NHI during the public hearings, the provincial public hearings. So, with that said, Honourable Minister, I'm going to allow the members to raise their questions. I just need to say that we might have load shedding at 11 o'clock. I do have an alternative energy source and network source, so there would be a minute or two when I might be cut off and I would have to reconnect to my other source. The members who want to raise questions are firstly Honourable Ismail, then secondly Honourable Sukacha, thirdly Honourable Wilson, fourthly Honourable Chirwa. Honourable Sukacha is on the struggling with the network, but he's going to try his best. He's posed two questions to us on the group, which I would raise if he cannot. And then Honourable Van Staden unfortunately had to leave the meeting. And then, yes, number 6, who does 5 is Honourable Soekers, and 6 is Honourable Dr. Themba Kwayo, 7 is Honourable Maslengwa. I'm going to repeat, it's Ismail, Sukacha, Wilson, Chirwa, Soekers, Themba Kwayo, and Maslengwa. In that order, please raise your questions. Thank you.
Good morning, Chair. Good morning, everyone, and thank you for the presentation. I have several questions. My first question, it was reported in the news that a mental health patient in Durban died after eating food that was a week old. Now, in this report on slide 20, there is evidence that the department did not conduct any hospital assessments on food and services. The reason for this was due to travel restrictions and COVID. Now, what plans have been put in place to catch up on lost time with regards to assessing hospital food quality? There is also mention of traveling to various provinces, and if travel is an issue, is there no possibility for the Department of Health to use officials in those provinces rather than external officials? My second question, compliances and monitoring seems to be a continued weakness of the department. How do you foresee the quality of compliance under the proposed NHI with the current issues the department is facing in this regard? My third question, how many nurses from our nursing colleges are absorbed into the departments? And please advise what is the current nursing vacancy rate? My fourth question, with regards to the program on slide 30 being screening capacity, it states that the budget spent for this is zeros. What is the reason for the zero spending? My fifth question, I've been receiving many inquiries about booster shots for the over 50s. Now, going forward, it would have been 6 months since the first people got their second Pfizer jab. Please advise when will this start, or is this in a trial stage? My sixth question, with regards to the clinics that do not qualify as ideal clinics, on which areas are they located? I mean, which areas or provinces are these clinics located mostly? And my last question, please advise what is the total amount spent within the Department of Health on legal costs for corruption and disciplinaries. Thank you, Chair.
Is Honorable Sukacha next? I'm going to read his questions. If
No,
he
can
is
I read
not
it,
able
Chair?
to-
Can I read it, Chair?
Yes.
Thank you very much, Chairperson. Let me welcome the report from the Minister and from Acting DG and the Acting CFO. Just two questions from my side, Chair. I heard Dr. Chris mentioning that the provinces underspent on the conditional grant, and all provinces. I was just interested on the amount per province. What is the amount per province? He might have mentioned it was, as I've indicated, I'm on the road between Uppington and Kimberley, so the signal is very bad. I'm standing along the road now just to ask my two questions. If he did mention it, my humble apology. Then the second one, Chair, is around the nursing colleges. Chair, provinces are training nurses. I want to couple it with the program of the Cuban doctors. Provinces are training on their own budget, the nurses, they are training on their own budget, the Cuban doctors. But my only concern here, after these people have completed, it seems to me that there is no retention strategy. I don't know, is it based on their budgets or what is the problem? But you find a situation where most of the nurses that have been trained in a particular province, working in other provinces, which is not a problem for me because it's still the health system. But the issue of the budgets, they are training them and the vacancy rate is so high in a particular province, needing these nurses, but they cannot retain them. What is the problem? And even the doctors themselves, these Cuban doctors, out of their own budget, they train them, and then province needs the doctors because of their vacancy rate, but they cannot retain them. What might be the problem? Those are my two questions, sir. Thank you very much.
Thank you, Chairperson. Thank you. I've also had to pull off on the side of the road. Okay, so just one quick. I have a lot of questions, but I could keep the minister and his team busy all day. I just want to deal with the unauthorized expenditure of, according to the FCC, of 49 million. The acting CFO did say that 30 million of that was to KwaZulu-Natal, which they have since recovered. My question then is, okay, so what happened to the other 19 million, and what is that unauthorized expenditure for? And the other is a statement. Having had the presentations from the FFC and the AG, there's very big concerns with regards to the Department of Health, and particularly their statement that the NDRH, in the NDRH, no investigations have been done or initiated, particularly around supply chain management. And the end result of that, there has been no consequence management. And this has become abundantly clear. Because we had our ex-minister and his buddies climb in on the act because nothing has ever been done about this. The situation has not been sorted out, and there has been no consequence management. If we do not address this very quickly, we are going to see this ongoing for a long time. And all these monies are lost to people on the street who need healthcare, who are now not getting it. That's a statement more than a question, but I thank you, Chair.
Thank you very much, Chairperson. Sorry, I'm struggling with network even today. My questions are as follows. Give me a second, Chairperson. Thank you. Thank you to the NDOH and the Minister for their presentation. I wanted to ask firstly to the Minister what the position of the department is on the discontinuation of the low-cost benefit option. Because we know that the CMS released 2 circulars in 2019, which will be in effect from next year, March. That will see the low-cost benefit option no longer being available. But we obviously have the knowledge that this is a medical alternative option that is available or that is used by people, primarily the working class, your petrol attendants, your domestic workers, and even unemployed people who don't afford medical aids. And second to that, who don't have the convenience of time of having to go to the public healthcare system, of having to wait the whole day at clinics that only open between 8 o'clock and 4 p.m., but need healthcare or need chronic medication. So I want to know why the department hasn't said anything in regards to this particular thing, because it's something that we should be taking as a big concern. So I want to know what the minister and the department's position is on this particular thing, especially because the CMS says this is in preparation for the NHI. The NHI will not be fully implemented even in 2026, and that they know already themselves. They know that it will not be a waking reality as soon as possible. And the last thing that we should be doing is to now influence or impact one of the poorest cohorts that have to access the public healthcare system that is already overburdened, by the way. And the minister will know this as well. And then secondly, I think we'll be going in and out and back and forth as we do every year. The department and the entities are regressing each and every year consistently and sustainably. And now I think we should start swaying away from what will you do as a department, what will you do as the minister, and you must start accounting more than that. Because it cannot be that the public healthcare sector is in shambles. And then each and every year in and year out, you are coming back to tell us you've improved when we know that you have not improved, that you have regressed, in fact, steadily, even as per the assertions of the Auditor General. So I want to know what then becomes the consequence management of the fact that you, minister, and your team are failures. You are failures. South Africa is now faced with a debilitated and collapsed healthcare system because you have failed as a government. You have failed. I want to know what must we do as a portfolio committee with your failure as a minister, that from this entire time, and we can't even just mark your presence as a minister just from now, because you've been the deputy minister even before that. So generally, you're part of a cabal. You're leading a group that has failed the people of this country in delivering sustainable and also capacitated healthcare. It is not growing. You are stealing monies. You are corrupt. It is just, it's a show, really, of what's happening in the NDOH. Can I just speak and finish, please? Just because my words are touching you the wrong place.
I want to remind you, Honorable Chirwa, on your choice of words. The word...
It's not personal. I'm talking to the department. I'm talking to the department. The department is corrupt. Why are you fighting the word corruption? Why can't I say the word corruption in the portfolio committee meeting?
You said that the minister is stealing.
What rule is that?
Honorable
Yes,
Chirwa,
did they not steal? Did this stuff not happen?
Honorable
Did it not happen?
Please, don't go down this road. Just wait for
Don't provoke me, because I'm speaking to the minister
Chirwa,
as I should.
I will have you removed if you keep on using.
That's all you do. That's all you know. That's all you know. Just to massage the laurels of those who feed you. That's all you know. You can't. I'm not here because of you. Chairperson, I'm not here because of you. I'm representing a constituency, and you will respect that.
Honorable Chirwa,
you will respect that. I'm speaking to the department. I'm speaking, and I'm allowed to say corruption. I'm allowed to say corruption. I'm allowed. Since when can't we say corruption?
Secretary, please ensure that Honorable Chirwa is removed from the platform. Thank you.
You deserve each other, you corrupt Mogogans in this committee with the ANC.
Secretary and ICT, thank you very much. Let's continue, honorable members. Number 5, Honorable Sukers. Let us be reminded, honorable members, to use proper language when we speak to each other and to be respectful to one another. Please.
Person, we are all adults here. We cannot be undermined like this as if we are children here and allow a member to be a headless
Thank
chicken.
you, Honorable Sukacha. I am in control of my meeting. Thank you very much. Honorable Sukas.
Thank you, Chairperson. Let me start by just thanking the department for the presentation and the report, and especially given the situation and crises within the department with the senior management team being in crisis. Chairperson, I am going to speak to the presentation in broad strokes, and I think the worrying trend, not just with this department, it's across departments. I sit on 3 committees. It is the organizational capacity and ability to provide leadership on the high priorities as set out by the government. That is the concern. The department rightly states its role as providing leadership and enhanced governance in the health sector. Yet the department has been beset by issues severely affecting its credibility, and this points to organizational inefficiency and a culture of impunity that exists within the department that allows flagrant mismanagement and corruption. Now, the passion and I think for many people or members that are working on the ground with their constituency, that are confronted with the questions by communities, the health crisis situations, it becomes emotive, and we are in the part of the year, and I'm not excusing anything, but I think we're in the part of the year where emotionally people are feeling it, especially if you are working within your constituency and you witness the failures, service delivery failures of the departments in real time. And so my question to the department is, what plans are being put in place to affect organizational redesign and change in the department? Because you are providing leadership, because you have a high priority in terms of transforming the health sector, of which NHI is a total redesign of the health system. The credibility of the department in terms of governance is a major issue that must be addressed, and you will have to address it in your communication to the nation as well to the representatives that are sitting here. It is problematic when we are dealing with operational issues, and yet the organizational leadership issues are staring all of us in the face. Nou, ons kan nou regtig wees soos dronk mense nie. We can't walk and do the tick box exercise in a committee meeting, look at the operational issues as reflected in your numbers, without us, from a leadership perspective, speak to the issues of leadership credibility, because it does translate to how your messages are received from a health perspective. And our chairperson has very well said that the health of the nation is actually on the table. So when you, from a leadership position, fail in that aspect, actually it has dire consequences across all other sectors and across communities. So from an organizational redesign, if the minister is not able to give us an answer now, then certainly there should be, chairperson, a presentation by the department to say, how do you deal with the gaping wounds that is evident within this organization, within this department, in order for us then to sufficiently address, of course, the high priorities. But it is problematic. It's a deep, deep concern that I must express here, that we're not dealing with the capacity issues. We're not dealing with the leadership issues. And those issues are actually critical if you want to speak of execution of strategies. So then my next question, which has been alluded to as well, the issue of procurement and strategic sourcing. Now, I have brought this up in relation to vaccination. I see this also across all departments, basic education, now with health. And we deal with things at a basic level, which is contract management. That is at a basic level. If you look at an organization, chairperson, at a strategic level, you talk about strategic sourcing, which has to do with how we procure goods in order for it to be cost effective and profitable for the organization. Why is it so difficult that the biggest organization in the country, which is the government, doesn't demonstrate the kind of discipline that will ensure that taxpayers' money is being utilized at the basic level in a principled manner, and then at a very high level at a cost-effective manner to ensure that we are actually making sure that we're running a profitable operation that will be to the advantage of our people. So I'm going to ask the question again. What is being done to ensure at a very basic level that contract management guidelines are being adhered to, and this translates to your performance indicators for people that are working within the supply chain processes? Then secondly, what are you going to do to give capacity from a strategic sourcing level to ensure you have the capacity that government actually function at a higher level when it comes to sourcing? Ons kan mos nou regtig met soveel geld werk op so 'n basiese vlakkie, chairperson. It's extremely worrying. And it is worrying to us as people, as representatives of the people, because we see the translation of failure on the ground, and it concerns us because I know we all love this country. So let us do it in a better manner. So I hope they've got the two questions. Then I want to know, chairperson, I've spoken about procurement. Then there's a second element again. Again, it's about processes, and it is worrying. The vaccine rollout, the initial vaccine rollout I'm talking about, has been compromised by factors such as a lack of research, failure of communication, and I won't even go into directives and all the things that is translated in terms of that. What research has been done to determine and track the South Africa's intention to be vaccinated? I know we had a presentation before that I asked the same question, and I'm not certain if it has been answered. Just indulge me and answer me on that. And then, how many of our people intend to be vaccinated, and what research has been done to determine the causes of vaccine hesitancy? And again, of course, I don't need to frame it. I am framing it within the context of you giving out this amount of money, you have on the softer issues, this amount of people that are hesitant, it has major implications. So if you, from a research perspective, can answer that. Then linked to that is the view of vaccination without parental consent. Now, Dr. Crisp went on national TV and stated that children as young as 12 can be vaccinated without parental consent. Again, we're talking about how you convey a message which has to do with your organizational capacity to ensure that people buy into your messaging. Informed consent is a foundational ethical concept in healthcare. And in my experience, very few children are able to give informed consent. Lack of informed consent is evidence of a corrupt healthcare system. So to attack the family in this way is wrong, and it's an intrusion. This is a comment of the state into the inner sanctum of the family. Would Dr. Chris please tell us how many children have been vaccinated? How many have been vaccinated without parental consent? Did he obtain a written, formal legal opinion from the DOH legal department before making the statements he made on child vaccination? And did he obtain legal opinion from an independent senior counsel before making these statements? Again, in the presentation, there was a reference to the legal framework. So it is from that perspective that I'm asking the question. If he did not, why not? And if he did, can he forward these opinions to the committee? Then lastly, Chair, what plans are in place to use schools as COVID vaccination sites? Is the department planning a COVID mass vaccination campaign of learners in conjunction with the DBE? And how much money is being allocated to these programs if they are planned? And then I note that one of the aims is to improve community engagement and to reorientate systems towards primary healthcare through community-based healthcare programs to promote health. How does the department envisage doing this? And is it willing to make provision of state healthcare services in the community subject to the control of the community, and to bring community level accountability that moves beyond community empowerment? I've said a mouthful, Chair. If they need me to repeat, I will, or if they want me to send it, I will, through you, Chair, send you any other detailed questions if you would indulge me with that as well. Thank you.
Thank you, Chairperson. I think I'm next. But before I ask my questions, I'm going to start by reading Honorable Naledi Chirwa's questions, since she was kicked out of the system before she could complete her questions. And to humbly, before reading her questions, to say to the chairperson, I think it's high time for us to have our own meeting and discuss on certain things that needs to happen in our department, as we asked even before, during the time of the deputy minister, to say we need the intervention of the speaker in our committee because of certain things that are happening that are not desirable. And at least also to have a suggestion of how we can solve other problems rather than kicking other honorable members out of the systems when they express their minds. The unreported questions from Honorable Chirwa reads as follows. Surgical mesh 2017 debacle alert was raised on J&J meshes that they were corruptible. However, there are patients that received these devices regardless, and Pindile Mube is one of them. 1. Reasons for this. 2. Calling for an internal investigation on the general mesh complication crisis in the country. How many people receive this information on how many cases of surgical mesh complications currently suffice in the country? Interventions by the department in conducting removal surgeries like in other countries. And lastly, a way forward in ensuring corrective surgery for the victims, asking that the department consistently report back to the committee on this request in written form. The other one, discontinuation of vaginal mesh. How will the department work towards this goal, or in the very least, conduct investigations into the outcries of mesh survivors who are organizing as mesh awareness activists in the country currently? The role of SAPRA in this process, noting their misleading of Parliament previously on never having received a grievance when they had in 2017 already. Following up on forced sterilization commission, deviations and exceptions, how does the department plan on resolving crisis of failing to comply with these legislations? My questions are as follows. The Auditor General reported that the financial statements of NDOH submitted for audit has not been prepared in accordance with the prescribed financial reporting framework and supported by the records that were needed. This is a framework or a matter of supporting, sending the correct information. And furthermore, it is stated that material misstatements, can you provide reasons why and how are you going to remedy that? Yes, I had those who were reporting, talking to us on audit improvement plans, but that is just a general word. It's not specific. It doesn't specify today to say which aspect are you going to improve and how are you going to improve it. I mean, these are the problems of the National Department of Health. And secondly, it is said that some people who worked in the department and who had a private or business interest in the contracts awarded by the department failed to disclose such interest. We learned that disciplinary action was taken against some of the officials involved. My question is, who are the remaining officials outside the some officials that were disciplined? And when are they going to be identified and exposed? When is the anticipated time of the disciplinary hearing to take place against such individuals or such officials that are not mentioned to date? In connection with Program 6, Health System Governance and Human Resources, the AG was unable to audit the reliability of the achievement of 76 PHC facilities. How is your department going to make sure that the 76 PHC facilities do report on reliable information? The following question: can you brief us on the latest situation in the Northwest Provincial Department of Health? Next, what health promotion intervention in the department implementing? What is the health promotion intervention in the department that you are implementing with regard to antenatal care, especially in the rural areas? Can you report on the state of EMS in the country? During the election period, Minister, the records of COVID-19 were very, very low. Immediately after the elections have taken place, there is a mention and it's echoed throughout of the occurrence of the fourth wave. My question is, who is controlling this occurrence of this COVID-19 waves? Is this not business for other companies who are benefiting financially in this COVID waves? Thank you, Chairperson. Thanks for this opportunity.
Honorable Mahlengwa, followed by Honorable van Staden.
Thank you, Chairperson. First of all, let me greet the department. The report that is clear.
Honorable Senghor, did we lose you? Honorable Senghor. Honorable van Staden, please continue, Salon.
Thank you, Chairperson. I've just got 3 quick questions. In the previous report we received, I think it was in September, we were already in recess of Parliament. Under Program 5 hospitals, there was an amount, I think, speaking under correction, I think it was 85 million wrongly paid over to provincial, one of the provincial departments by the National Health Department. I just want to know, my question, this is, has per transaction been reversed? Is the money back at the National Department of Health's coffers? My second question is, there was a report yesterday in the media about the National Department and the government who's selling the COVID vaccines to private companies. I just want to get clarity if it is indeed so, and if so, is it now allowed for private companies to procure COVID-19 vaccinations on their own and not through National Department of Health and on government? You remember at the beginning of this year, we had this debate about the procurement, storage, and outreach of vaccinations. So I just want to know, is the private companies now allowed to procure on their own COVID-19 vaccines? I think the third question I had was, just want to apply my mind quickly. yeah, on the latest stats of COVID-19, the numbers is relative low. I see we have a good rate of 96% of people who is not infected. So it looks like we're getting healthy. I just want to know for government, and that's like my previous colleague has said, everybody is now speaking of a fourth wave. But we have entered the elections, we are through the elections, we are going to Christmas. Is there any indication from the National Department of Health of on which dates the fourth wave can be expected? Because according to the numbers that I'm seeing now, it doesn't look like that is going to happen any case soon. Thank you, Chairperson.
Very much, honourable members. I will now ask my questions to the Minister. Minister, congratulations on your unqualified audit opinion, but the AG finds material misstatements continuously in the financial statements of the department. And although the department has had 10 years of unqualified audit opinions. Question is, what are the plans of the department to provide feedback on any planned action plans and whether there are such action plans in existence, and also progress on those action plans to address the poor audit outcomes on a quarterly basis? And then secondly, what is to be done by the department to prevent irregular expenditure in the future? And in terms of that irregular expenditure, what is the role of the department to assist provincial departments of health to address increasing levels of irregular expenditure? And then in terms of your accruals, the question in my mind is, what is the department planning on dealing? How is it going to deal with these accruals? And how is the department assisting provinces to deal with the accruals? So in additional to all of the questions asked by the members, I know these are quite a number of questions raised, Minister, but you're very welcome to answer these with your team. Thank you.
Thank you very much. Thank you very much, Chairperson. And let me also thank all the members who have put questions. We will share the responses with the management team and the Deputy Minister. From Honorable Ismail, I'll just ask the acting DG just to allocate. I'm sure from environmental health, we should be able to respond on the issue of food quality. And the chiefness, I hope is on the platform, unless somebody else on the nursing vacancies. And the acting DG just to say something about the Pfizer booster. Let me just say on this one that at this stage, the only booster offering is in terms of the Sisonke 2 study undertaken again by the Medical Research Council using the J&J. And the reason for this is that at this stage, there is no general recommendation either from the World Health Organization or overall in terms of various regulators, including our own. As you would be aware that these vaccines were approved for, in terms of a particular application and usage. And at this stage, we are aware that there is a lot of experimentation and kind of trials in various parts of the world, and individual countries and regulators have made certain decisions, but from our side, the only additional doses which we have approved have been very specific in terms of people with particular immunodeficiency conditions, including those on cancer therapy, chemotherapy, radiotherapy, including those who are on renal dialysis, those on autoimmune treatment with steroids. So there are specific areas in which we have approved on the doctor's assessment and recommendation for those additional doses. But because of the fact that there's a whole lot of speculation, that's why, and again, prioritizing the health workers, that's why we've agreed with the Medical Research Council to apply to SAPRA, which has been approved for an additional study which will entail a second dose or a booster dose of the J&J for those who, the health workers who were the first ones to receive first vaccination through the Sisonge, the phase 1 Sisonge trials. So this will help us to get more information. And we have said that in terms of the others who have been agitating for Pfizer third dose as well, because Pfizer is a 2-dose. But what we have said again is that this, we must follow the same processes. You know, we can't say on when other matters you know, have to be applied, we must follow the science and what is proven and what has been approved and assessed to be that it can be done through the regulators, in the same way as the J&J booster dose study is happening. If there is a desire to look at a third dose of Pfizer as another study to see, because at this stage, the Pfizer vaccine is approved as a 2-dose full vaccination. So if there is any desire to go that route as well, let it follow the application, be assessed by the regulator, what would be the protocols if that kind of assessment. But we are not at the stage, either through world bodies' recommendations or through our own regulator, we are not at the stage where there is sufficient information through proper authorized bodies to can actually start looking at the route of offering general booster doses for general members of society. My apology. So, but I'll ask the team, acting DG and other members of the team just to take up on that. And then also, I'm sure from corporate services, the issue of cost of legal action and disciplinary action, that also can be undertaken. Now, Honorable Sokacha, I think the underspending acting DG will deal with the training of nurses and who are not retained. This is indeed true. Now, the problem with this is that the reason why people who have been trained at the taxpayers' money expenses are not are not always all of them on completion employed by the same departments. It's basically that the desire is there and the need is there, but because of, as the CFO has indicated, a progressive decline in the budget allocation over the years and even the years going forward, until the revenue situation can be stabilized. Our provinces are just finding themselves in very difficult situation where if they don't limit further employment, the cost of employment as a budget line just crowds out all other budget lines, such as maintenance of equipment, upgrading or maintenance of facilities, purchase of consumables such as medicines and surgicals, and many other consumables, including food and so on. So colleagues have to balance the situation in which they find themselves. And that's why at the cost of the taxpayer, young people get sent for training, but at the end, they cannot all be absorbed, not because they are not needed, but because of the budget shortcomings. Honorable Wilson, I think that matter and I think Honorable Van Staden also raised that question. The acting CFO has dealt with, but he can come back on the unauthorized expenditure but you wanted to know, he has accounted for 30 million and the total is 49 million. And I'm sure he will be able to respond to that. Now, in terms of investigations, honorable members, I believe that we do have fairly robust check and balances. We have an internal audit function within the department, as is a requirement by law. We also are audited by the Auditor General. And quite a lot of time, we can't just go on a general investigation of procurement processes, supply chain management, unless if there's a red flag somewhere, either through the internal audit or through the Auditor General when they do spot checks, not just the annual audit. In the advent of COVID, the Auditor General is looking at our expenditure very robustly, just in terms of COVID, but also now with the vaccine program, almost on a weekly basis, we do get audited. So I believe that we do have robust system of checking on irregularities. We here and there some may be missed, but once there's a red flag, that's when we can be able to go into a deeper investigation, as it has happened in the matter which is well known on the Digital Vibes matter. The issue of the low cost benefit, I know that we have discussed this. The Council for Medical Schemes, its mandate is to protect the consumers in terms of health insurance products. So they continuously have to approve products and schemes and how they operate to make sure that this is in the interest and protection of consumers. And part of the dilemma which they have raised, we're still going to have further discussions with them, but I'm aware that part of what they have raised in terms of these low-cost products is the fact that in their own assessment, many of these products, they're actually more on the actual cost of administration of a major portion of what the members contribute to what they believe is going to cover them. The actual coverage is very limited. Just reading their report on this matter, they were indicating that some of this low cost, they promised, for instance, GP cover on the primary health, are known to the consumers that they're only entitled to 3 visits to a GP in a year, just as an example. But also that a lot of these products spend more out of the members' contribution. A bigger portion goes into the cost of administration than into the actual cover, the benefits for the individual. So they have to grapple with this, and in the process of trying to protect the consumer, sometimes they may be seen to be harsh, but that's really the basis. But that's a matter which is, because we are also concerned that where there might be a proven benefit, while the NHI is still coming, whether actually some of those can be protected. But we also can't stand in the way of the regulator, Council for Medical Schemes, if they do pick up actually that a product which looks very good on face value on the marketing, but in substance, in terms of benefit to the public, it's actually very little. So that's a matter which I'm sure at some stage, even the committee could be able to engage with the CMS, but they've got very logical arguments in terms of some of the products which they've had to take steps against. I'm trying to come back to Honorable Chirwa's issues. Well, Honorable Chirwa makes also very sweeping statements about and this is, I know that having been in this portfolio for some time, she's always making these sweeping statements that the department has failed, that all of us are corrupt, that the system, the whole system. I'm sure. I don't know whether the honorable member, in fact, can really go out and tell the thousands of hardworking health workers, risking their lives in the middle of a pandemic, saving so many lives. And I really don't know how she comes to what on the basis of what analysis and research does she come to this. Just to also say that a few months ago, one of the research companies which were assessing the confidence of the public in various public services did find actually that health was coming out much better than many other public services. In fact, I remember that the person who was questioning this researcher, it's one of the reputable research companies. Now, the TV presenter could not believe it when this person actually said that in the public, what they found out was that health services, notwithstanding the pressure under which they are, still enjoy a lot of confidence in the majority of members of the public. So I hope Honorable Chirwa could be able to be assisted to do a little bit in-depth analysis of. We don't dispute the fact that there is a lot of pressure that our institutions, our professionals, our professional nurses, doctors, and all other health professionals are working under a lot of pressure, but they're doing sterling work in saving lives and making sure that many more South Africans could survive from the pandemic and many other in the quadruple burden of disease. So would really encourage her to look at the, also in a balanced way, look at the positive side. Honorable Sukers, indeed, we agree that we do need to strengthen our organizational design. As Acting DG will indicate, we are continuously looking at improvement, including in terms of our organizational structure. There's been a lot of relook at the structure. We are also in discussion with the DPSA in terms of improved organizational structure of the department. Also looking at, we accept the fact that with what has happened a few months ago, we did suffer a lot of credibility gap in the public, and that's something which we intend and almost best to make sure we can communicate truthfully to the public, and where we are not able to fulfill particular expectations, we should be able to honestly say so. So indeed, we are doing our best to make sure that we can improve in terms of our organizational capacity, redesign, and leadership, as you have said. Of course, on the issue of vaccines, we are aware that yeah, you have particular questions which you have raised about whether we have done research as to whether South Africans actually accept the vaccine. Indeed, I mean, when we didn't have the vaccines, the cry out there was, why is government not providing the vaccines? Now we're providing the vaccines. Of course, we accept the fact that as public service, you get criticized when you don't provide something, and then you still get criticized when you do provide what people have been calling for. So it was never really our belief in terms of knowing that the information and the evidence was out there that vaccines do save life. And even in our situation, even after rolling out, to the extent that we have done, the evidence is there that the vaccines do save life. So we don't believe that over and above information available throughout the world, that we needed to first, before we could even, I mean, once the vaccines were proven to be effective and safe, that we needed to first do a survey as to whether people will accept them or not. We have rolled them out. We've rolled the vaccines out. We're still rolling out. people are coming forward to take the vaccinations. Of course, we admit that at the current moment is not at the rate when we started and at the rate which we desire, the rate at which we are capable. But we're doing everything to encourage more people because we know that we have no doubt about the fact that the vaccines are effective and they are safe. In as far as the vaccination of children, Acting DG will be able to respond for the allegations you have made about what he has said. Our position is that we follow the law and that in terms of the Children's Act, in terms of medical treatment, children 12 years and above are taken as being cognitive enough to can make decisions in terms of medical care. And that is what the law allows. But we have also said that we would want to encourage that this be done under the support of parents and guardians. But what we are saying in law, if a 12, 13, 14-year-old comes forward and says, I'm ready to take the vaccine, I understand you, and after counseling, they insist that they are ready, they understand everything. As a health provider, you have no legal right to refuse. But we have said very clearly that our preference would be for guardians, parents and guardians to also accompany them. The issue of surgical mesh, Honorable Tembekwayo, on behalf of Honorable Chirwa, Deputy Minister Dlomo will deal with that. And there's a lot of matters Honorable Tembekwayo has raised, which have to do with financial statements, which the acting CFO will be able to deal with, including material misstatements. The issue of disciplinary action for officials who are found on the wrong side, in as far as the areas which have been investigated, that process is ongoing. As we promised the portfolio committee when we gave a report earlier on at the end of September. That process is already very well advanced, but any other who are found to be on the wrong side will be dealt with accordingly. I think other matters which arise from the AG's report, the acting CFO and the other team members will be able to deal with. Maybe acting DG and the team can deal with the issue of emergency medical services and also the issue of health promotion. Let me just, the issues from Honorable Van Staten. The issue of, I think the other matter is the same matter of which has been raised about the, it's a matter which was raised about unauthorized expenditure, a certain amount which Honorable Van Staten quoted a different amount, but I'm sure the team can deal with that. His question, again, I'll ask also acting DG just to add on this, whether a government is selling vaccines to private companies. At this stage, we do work with various private companies in terms of availing vaccines to them so that they can also be able to vaccinate those who are covered by medical schemes and also those who are not covered by medical schemes. And for those who are not covered by medical schemes, we do reimburse those private service providers for the cost of the actual service and also for the cost of the vaccine, where because they pay to get the vaccine from the supplier, from the storage, from the warehousing, and we have to reimburse them for that. But let me just clarify on this matter that the government has never put a ban to say private companies can never purchase vaccines. We said that we would prefer that the purchase of vaccines be done through the state, but we never really put a ban. But it was the vaccine suppliers themselves who preferred to work with government in supplying the vaccines. And because of the fact that we're able to acquire this vaccine, sign the contract, it became actually redundant for any private company to then go out and again source vaccines when actually they could, if they were to vaccinate at the companies, for instance, the mining companies, any employers overall, all the employers, we work with them at the works on the occupational sites. There is a program on vaccination on occupational sites, and this is through supply of the vaccines by the state. So it became redundant actually for companies to even venture into acquiring their own vaccines. The question of the fourth wave, also maybe dealing with Honorable Tembekwayo about the fourth wave. What is very clear, honorable members, is the fact that while the infection rates are low now, and we're all crossing our fingers that they remain so, we know that from the experience of the last almost just under 2 years, this has been a cyclical event where the infections go down and then, driven by variants and also by movement of people, the rate of infection suddenly spikes up again and creating these waves. And we can see also the pattern again. Most of Europe is already under the fourth wave. There are lockdowns happening. Infection rates are very high, almost the entire Europe. So, and in the same way as it happened with the first wave, in a way that with the beta wave as well, a similar pattern. The Delta wave, which we just went out of, started mainly in India, and after some time also reached us. So the fact that once you see a high rate of infection across the oceans, the pattern is quite clear that it's a matter of time. So the more protection, the more safety measures we take, the better for all of us. Let me stop there, Honorable Chair. Maybe firstly, just maybe if we can get the acting DG, and then, or maybe before we do that, let me ask if the Deputy Minister wants to come in, and then we can, and the one or two areas where he may add, and then acting DG and the team can then do details of the rest. With your indulgence, can we give a chance to the Honorable Deputy Minister?
No, thank you very much, Minister, and good day to the leadership of the Portfolio Committee Chairperson. The matter that the Minister is asking me to deal with is regarding the surgical mesh and the question of Honorable Chirwa. On the 23rd of August, I received a message from Honorable Chirwa, and then we started discussing this matter. In our discussion, then Honorable Chirwa gave me the number of Ms. Pindile Mncube. Pindile Mncube then got admitted subsequently at Steve Biko Academic Hospital. And I was very fortunate to be able to speak to the head of department, ONG, there to ask them to support her in whatever she actually was asking for. Subsequently, on the 21st of September, Honorable Chirwa accompanied Ms. Pindile Mncube again to Steve Biko, and the message I received from Honorable Chirwa was that, yes, we are being attended to by the specialist, and they will update you, Deputy Minister, if we need to get further support. But then in October, I saw a message in some social media written by Ms. Mncube, and then I contacted her because I do have a direct number. I contacted her and I said, look, can we assist further? I see that you have not really been satisfied. And then I then said, because you're a resident of KwaZulu-Natal, I will make an arrangement that you go to Inkosi Albert Luthuli, to the office of the CEO. She's already waiting for you. Then she will take you to the head of department of ONG. And I would not go into details of what actually our discussion was like, but suffice to mention that Ms. Mncube declined that arrangement we were making. But just last week, on the 12th of November, I received a call from Honorable Chirwa again on this matter. And then, and she did indicate to me, Honorable Chirwa, that no, Ms. Mncube has now changed her mind. She would like to be assisted. Can I rearrange? Then I did rearrange. She went to Inkosi Albert Luthuli, seen by the professor of head of department of gynecology and obstetrics, who then convened another team of other surgeons to assist her. She was then assisted and referred to Mahatma Gandhi Hospital, where I am aware she's being attended to. I spoke to the head of department just last week that she was given all the information that will actually assist her in the matter that she's raising. So I am specifically attending this matter because the Honorable Chira does call me, and then we do work on it very cordially. So we are keeping Ms. Mube on our radar screen in terms of assisting her. But just on another matter, Minister, which I know that our acting DG will attend to, that was raised by Honorable Sukers. This question of vaccination in children is coming very frequently. And you are right, Minister, we are guided and supported by the Children's Act. And I was just reminded that there are child-headed households, and there are certain children who are making very bold decisions because they have nobody else to refer to. I mean, like basic things like, what am I going to cook tomorrow? And children are making decisions like, should I go to school tomorrow, or should I go to the SASA grant and collect the grant for the family so that you can live? So children are already making very major decisions. And this is just but one of them. So the Act is actually supporting those children to say, in the absence of a grandmother and a mother, and you are a child-headed household, what decisions can be made? And this is, among others, covered in that. I just thought maybe I should add that to say, yes, in the Zomo family, the child should and must still consult if there's a family support. But what do we do with children who are child-headed and they have nobody else to consult? Thank you very much.
Acting DG, you can take the floor.
Thank you very much, Minister and him, and for those. Just so that others can prepare, I'm going to ask others on the team to deal with some of the questions. So the questions that are related to nurse training and retention, Maggie Rabangani and supported by Dr. Kobe Mare can prepare themselves to answer on those questions just now. And then Mr. Morawani will answer the questions related to primary health care about ideal clinics and where we may still have non-ideal clinics. There were also some other questions about food, which he may have the answers to more readily than us, and the emergency medical services in the country. Then all the finance-related questions about unspent grants, underspent grants, the Auditor General. The acting CFO, Mr. Nevatalo, will deal with that, but I may also come in and comment on some of the things that are reported by the Auditor General, where we may differ with both the Auditor General and the Treasury, and we've been discussing with the Accountant General about certain things as well. There were the questions, the Minister has dealt with some of the questions, but I may add to those questions. But I think and then Ms. Rennie will give the answers or explain how we go about getting legal services and how we pay for the legal services and disciplinaries and what we've been busy with at the moment. But let me take the first shot and cover the majority of the other outstanding questions. So perhaps just to start off talking about where are we with the department, the national department. So Honourable Minister has already said we are vulnerable, and we know we are, and we have been through a rough time. It's been very widely known in the media. Even prior to the COVID time, our department has been in dispute with our own staff about Civitas building. We've had a lot of labour unrest over the last 3 years. And we've then dealt with a flood, and you've heard the acting CFO reporting about how our personnel have had to go and work in other government departments to get access to systems. Some of the paperwork was damaged during the floods, and we have subsequently moved to a new building. So we know that we've been through a bad time, never mind the corruption, which I'll come to in a moment. But where we are at the moment, looking forward, is we have moved into our new premises. We are situated in the AB Tuma building, which is the old Exaro building, which prior to that used to be the ESCO headquarters next to Puerteca Hoogte and the one military hospital. We have settled in quite well. There are still a lot of issues around, the finalization of the move. But with the rotation of staff and the finalization of our IT systems, staff are coming to work, and I'm personally very happy with the progress that we are making. There are a lot of vacancies in our staff, some of which were created prior to COVID, some have happened as a result of COVID, and some of which have just been attrition because people have retired. And right now we have a number of our senior managers on suspension, which, as I said, I will deal with separately. So I don't think any of this is a secret. It's well known and it's well publicized in the media. But perhaps just to give comfort of where we are. As we stand today, every single senior post has got somebody specifically delegated to be an acting person with the authority to act in those jobs. So the senior team, our executive, and the next level below the executive all have competent senior people who have been in the system and are managing their portfolios. The second thing is that we then identified the vacant jobs, and we have been advertising them. We prioritized those jobs, and I'm pleased to announce that 3 of our chief director posts, we have finished the interviews, gone through the screening of the applicants, and just yesterday, 2 of the 3 I signed, and 1 I signed a couple of weeks ago for the commencement of 3 new senior management and chief director positions. Regarding the deputy directors general, we have advertised the CFO post. We have advertised 2 of our the 2 technical DDG posts. We did not get sufficient senior applicants for the jobs, and we are embarking on headhunting processes as prescribed or provided for in the public service regulations. And that process for 1 of those posts has commenced. And for the other 2, we have to wait a certain period before we can commence them. We will commence those as well. We do have some other posts that are advertised in our pharmaceutical space. There's another senior post that's been advertised. So we have a plan, and we are busy filling the key positions. But our organogram is going to change going forward. We have anticipated the administrative support required to build the capabilities for the National Health Insurance, and we have a number of positions identified that we still need to create for that. That will be done through a goods and services supply system, because we did not get money on our budget for conditions of employment to create any posts other than the one that I occupy in my normal day job. So we are going about it through a different route to get people on contract to start the processes and building the capabilities to run the NHI. For the other directorates, there's some reorganization necessary, partly because of compliance with conditions from the Department of Public Service and Administration, but partly because things have changed since this organogram was implemented more than 10 years ago. And we are consolidating and moving a number of our functions into different spaces and harmonizing it with our programs. That will take a little bit longer. We do need the concurrence of Treasury, and we need the concurrence because of the financial implications. We will abolish certain posts that are vacant in order to create other posts. And then the actual organizational structure needs to go through a process with concurrence of the Minister of Public Service and Administration. That has been going on for some time now, and we will, in the new year, hopefully get to a point where we can implement the new organization. So we very much have a plan. In terms of our relationship with the provincial administrations, we meet regularly through the National Health Council Technical Committee, and at the minister's level with the MECs, there's the National Health Council. There are regular meetings that are scheduled meetings that take place 4 times a year. But now during COVID, we meet fairly frequently on special meetings. We had one yesterday where we go through, in fact, yesterday's was a regular one, not another special one. But we'd have items of mutual interest between ourselves, and there are subcommittees of those 2 big forums where technical work is done together with the provinces. So it's a very structured, you heard the acting CFO talking about the CFO's forum. And then we have another forum between our CFOs together with the provincial treasuries and the national treasury in what's referred to as the 10 by 10. These things are all functioning. We are generally happy with them, and we are confident that we are building back into a capable national department. So regarding the, I think it's important to mention that we do have a number of people on suspension still. So everyone knows our Director General is on suspension, and 4 of our other senior officials are suspended. There were others amongst them suspended in other government departments as well, not only our own, all as a result of digital vibes. So we have reached a point where the investigating officer, which is a senior counsel appointed by the state attorney, has concluded the investigations based on the initial documentation from the SIU. They have collected their own information, they've interviewed a lot of people, and the charges have been formulated and were presented to the suspended officials, and the process, the appointment of the disciplinary chairperson, the date has been set, and the process has been communicated to the people who are involved. They obviously get that nobody's been found guilty yet, so they get opportunity to prepare their own cases based on the charges that have been made. And that process is running. The process for the disciplinary, for the Director General is not managed in our department, not by our minister or any of the officials. It's managed elsewhere in government because Directors General are appointed by the President. So I want to assure the members, and I'm sure the media and the public are listening to this as well, that we are not sweeping anything under the carpet, but we are following due process. And sometimes one just has to be patient. That due process, in order to be fair, needs to be given its space to run, and that is what we are doing. As far as the other questions that I thought I should answer, I think the ministers addressed the question of low-cost benefit options. This is a serious concern to us that sometimes products are packaged as if they are going to benefit people in the public space. But when you start to interrogate exactly what benefit is being provided, it is so limited that it does not hold value. And in some instances, it's actually just an industry. It's a money generation exercise that does not provide any significant benefit. So I'm afraid many, if not most, of the low-cost benefit options that are available at the moment fall in that category. And we have a parliamentary question we'll be answering in the next parliamentary session, where we will give a lot of details on exactly why we feel, how we feel about low-cost benefit options. Because we are moving, hopefully going to move to a national health insurance framework as soon as and system, as soon as the bill is through Parliament, all these will become moot points because the structure of the financing and the payment for healthcare will change as a result of that legislation. There was a question asked, several questions, also from the Honourable Sukkers about the vaccine rollout. So, without sounding defensive, the science of COVID and the vaccines is changing on a daily basis. And the more information that becomes available, the more studies that are done, the greater experience that is collected around the world. And because of the digital world we live in, we hear those information very quickly. There's a huge amount more information now than there was a year ago when decisions were being made about which vaccines to buy and whether to use this one or that one or the next one. So we're not going to even try and defend, but with the knowledge available at that time, a decision was taken. So the research that is being asked about, we've recently been required to prepare or been asked for documents for a court case. And just at first look, the total number of papers that have been considered by our ministerial advisory committees is in excess of 50,000 international journal papers. So to print and make all those available and put that in the public space is almost a futile exercise because there's very few people in the specific environment that is able to read and understand and collate that amount of very technical information. Do we conduct research? Yes, we do. Just about everything we do is backed up with our own research. But you start off by collecting what is known around the world from colleagues who are publishing in reputable journals, and then using that information to fill our gaps. So we are very happy to provide, and in fact, if the honourable members would like to go to our website, the SA Corona website, you can find and the departmental website, you can find the reports of all the ministerial advisory committees, and in those advisories that they submit to the minister, they list the key documents and the key research articles that they have used in coming to the conclusions and giving the advice to the minister. Obviously, there's a lot of other research outside of that, and we don't get time to look at everything, but we have an impressive array of scientists and clinicians in our country who are extremely diligent about sifting through and giving us information on what they believe we should know. We also have a lot of research being done on how the public reacts. So never mind the science, but how the public is reacting. And so the question was asked about vaccine hesitancy. We have a big team at UCT. We have the Human Sciences Research Council and various parties who are associated with them, who are constantly giving us information. And we have a social listening group, it's called, coordinated and run through the GCIS, the Government Information Services, who are helping us to put together responses based on what's being heard. And one can imagine we have such a diverse society that we hear a lot of very different things from different parts of the countries and different parts of the communities within those parts of the country. So we are very happy to respond to any particular information, but most of this you will find on the website if you have time to spend. Otherwise, we can send the links to the Secretariat, and honourable members can find the information there. I do want to talk about children because the Honourable Sukkers asked specifically about what I've said on television. Now, I've been on television and radio, if once, then at least 20 or 30 times. I don't know how many, I've lost track. And many times I've been asked about children. So I want to say it for the record on this forum. Children are governed by the Children's Act as much as they are governed by any other piece of legislation, including the Constitution. We take our guidance from the legislation that is in the law books, in the statutes of the country, which this Honourable House participates in formulating. And that Children's Act has been in place since 2005 and has stood the children of this country well since 2005. And there's a provision in the Children's Act that children may consent to their own health care should they need to. Now, the Honourable Minister was very clear in his comments when he said, that is not our preferred way. We would prefer to see nuclear families, extended families, people looking after the children. We would prefer to see adults accompanying children for medical conditions and for treatment, for vaccinations and for everything. That's the preferred model for any healthcare practitioner. But that's not the reality on the ground. Many children do not have the privilege of even a guardian. And many children are beaten up and are assaulted by adults that are supposed to be protecting them. So our Children's Act, and this particular clause of our Children's Act, provides an environment where children can be cared for and can be provided with health care on their own recognizance. And the Deputy Minister said there are some children who are forced to make very difficult decisions every day, even about how to look after their own parents. So the provision is in the law, and we did get a legal opinion, and we will provide the legal opinion as to whether children are allowed to vaccinate based on the provisions of the Act, the Children's Act. That is not our preferred route. Our preferred route is that children will be guided by a competent adult. And our healthcare workers are trained, they are aware, and they know that they need to make sure that for every patient, whether they're an adult or a child, they must get informed consent and tell the patient what it's all about. So up to now, up to last night, just over 328,000 adolescents between the age of 12 and their 18th birthday have been vaccinated with one dose of Pfizer vaccine. there was one more question I thought I should deal with. So the question of the fourth wave, the minister did allude to. I just wanted to perhaps start with a highlight to say it's very complicated, and there are a number of factors. If we knew exactly what those factors were, how they were going to turn out, we would be able to predict a fourth wave and a fifth wave and any wave very accurately. But the fact of the matter is we can't. So we don't try and forecast. We do what's called scenario planning. We ask ourselves what if questions, and we have a very competent team of forecasters, our modelers who help us with this. And to try and just look at the headlines of what they look at, they will look at, number one, do we continue as society to use the non-pharmaceutical interventions? If we do, we have a measure of protection of spreading the virus. Number two, do we have immunity in our communities? We can have got that partly because we had a lot of people who got infected, but hopefully the majority of it is because we vaccinated a lot of people. So if we keep vaccinating, and we are getting close to 25 million vaccinations given now, if we have a lot of immunity from vaccination and from wild virus infection, that is good. And if we keep vaccinating, it gets better. But the third and the most difficult to predict is that this virus mutates. And we don't know when and how it's going to mutate. So globally, there's a monitoring program where we watch which variants, and sometimes the variants are subtle changes and sometimes they're quite dramatic changes. We monitor all of the variants and the subvariants globally through a screening program and on a particular digital site. And again, we have very capable scientific teams that are doing this in South Africa, and we support and work with the neighboring countries because of the movement of the people between our countries. So we are at the moment not watching any new variants of concern. At the moment, it's the Delta variant. So if the Delta variant remains dominant and we do not get a new variant, it means that as a collective in the country, we are better protected because we have been exposed to this for a long time through the third wave. If we get a new variant and that new variant is able to escape our immunity or bypass our immunity and requires new immunity, then we will get a larger wave. So we are watching very carefully. We're watching what's happening in Europe at the moment, as the Honourable Minister said. But we are also very closely watching Gauteng at the moment and a couple of other provinces because the numbers have been going up over the last 4 days. And we don't know if it's just a flare-up or if it's something quite serious to be concerned about, and whether that could be the precursor to a fourth wave. But we have a lot of very competent laboratory and other scientists who are watching it. So I think we can assure the public we will know when we think there's a fourth wave on the way. So I think, Chair, if I can perhaps leave my answers to the questions and take them one at a time. If we could start, I think, just with Ms. Rennie responding to the question about what we spend on our legal fees and disciplinaries. And then from there, I'll ask Mr. Morawani to deal with the primary healthcare questions. Thank you very much.
Thank you very much, Dr. Crisp. Honorable, good afternoon, honorable members, the chairperson and the members of the committee, Minister and the Deputy Minister. I will respond to the question of how we acquire services for legal services for our cases. As the acting DG has already said, we get our senior counsels appointed by the State Attorney's Office. So at this stage, we do not have the costing. They normally charge us after the fact once the services have been confirmed as rendered for every case, any legal case that we deal with. So that also includes our disciplinary cases. Other than that, under normal circumstances, we use government officials for disciplinary cases from other departments or internally for any case that we are dealing with, and they claim normal claims, either kilometers or accommodation for the cases that they are managing on our behalf. There was only one case where we had to go a procurement route, which is the case of the case that was indicated publicly by the DG regarding the internal investigation on the digital vibes investigation, and we spent in the tune of 497,000 for that particular investigation. That is all the response I have. Thank you, honorable members.
Thank you, Ms. Rini. Okay, Mr. Mariwani, will you take the questions I asked you to deal with, please?
Thank you very much, Acting DG, and thank you very much, Honorable Mayor, Honorable Chair, and Honorable Members, Minister, Deputy Ministers, and colleagues. There are two questions that are for primary health care. The one of the patient that died after consuming rotten food in a hospital. I must say, this is really regrettable and very sad. The department has a process in place of assessing service levels generally, looking at different domains, and food services is one of those. We do work with the Office of Health Standard Compliance, and we also have our own internal mechanisms through the Ideal Hospital Framework processes to ensure that we do assess. But as it would happen with any other assessment, I mean, things may change quite slightly quickly because the issues of cold chain and safekeeping of food may just change quite rapidly. So we have then augmented that process with what we call a nutrition service level assessment tool. We actually have it in our annual performance plan. We targeting to assess 98 health facilities that are providing food for inpatients. And if we take that as a percentage of total hospitals, it's around 35% of hospitals per year. We hope that in about 2-3 years, we'd have assessed all hospitals. And of course, they are not at the same level in terms of quality of services. So there are those that are more advanced than others. So we hope that with that, we'll be able to cover that aspect quite adequately. But I do regret, I mean, the passing away of a person after consuming rotten food, as it was reported by the honorable members. Regarding the Ideal Clinic, regarding the number of clinics that have failed to maintain or get the ideal status and which provinces are having higher numbers, the higher numbers are in the Eastern Cape, and it's not surprising from where we sit in because they have the highest number of clinics. There are 766 clinics, the highest in the country, but also because it's vastly rural, and rural provinces are known for having a relatively poorer infrastructure. So that's that, and that is followed by Limpopo, Mpumalanga, and the Northern Cape. Now, we have entered a new cycle, obviously. We have enrolled a larger number of clinics in those provinces to make sure that we take them through and reassess them again, and hopefully the picture will improve. I must say that the Ideal Clinic is progressing quite well because we have aligned the Ideal Clinic assessment tools with the tools of the Office of Health Standard Compliance so that we ensure that clinics are not overburdened with a lot of tools and being assessed several times. So OHSC has accepted that once we have done our baseline assessment, they don't need to do that. All they do, they just do external assessment. So in that regard, we are assured that our clinics receive attention at a very high level in terms of quality checks. So thank you very much, Chairperson. Let me stop here. Thanks very much, and over.
Thank you very much. If I can go to Ms. Ravangani, and if she needs to be backed up by Dr. Maria, then between them. But Maggie, if you'll take it next, please.
Thank you, Dr. Crisp, Acting DG, Honorable Minister, Honorable Deputy Minister, and Honorable Members and Senior Managers in the department. For me, I'm here to respond to two questions which were raised regarding the training of the nurses at the nursing colleges. The first question is about the issue of retention of the nurses or the absorption of the nurses after training. And also the second question is about the vacancy rates. So responding to the first question, the issue of the retention or absorption, it's not followed, but the process that we follow in the department, it's the normal recruitment process wherein posts are advertised and all the candidates apply, and then the best candidates get to be selected. So this is actually the process that we follow. And then on the second question regarding the vacancy rates, maybe what I could do is just to indicate that starting with the nursing assistants, in total, we do have 39,650 posts. Out of those, 35,946 are filled, and vacant posts are 3,704. When it comes to the category of staff nurses, the total posts that we have in the system is 36,961. Filled posts is 31,766. The vacant posts in this category of staff nurses is 5,195. Then the third category is that of professional nurses or registered nurses. This category, we've got total posts of 73,509. Out of these, 64,016 posts are filled, and the vacant posts are 9,493. Then we do have the fourth category. These are all the managers, which includes operational managers, some which are actually as in an assistant director level. These actually in total is 21,694. The field posts under this category of managers is 17,723. Then the total vacant posts in this category is 3,971. So therefore, in total, the vacant posts that we have is actually 22,363. So these are the number of the number of the posts that we have which are vacant in our system. Thank you. Over.
Okay, thank you very much for that. I'm not sure if Dr. Maria wanted to add anything from her angle about the nursing colleges. Covet? Okay, otherwise we'll go to the acting CFO. So I think we'll leave there many questions about money. I'm just going to leave Mr. Nebutalo to start with that, and maybe I'll end off with the last comment. Thank you.
Thank you, Acting DG. And there were a number of questions that were directed to the Acting CFO. I need to start by saying that I don't use it as an excuse. I was appointed in August, so this audit process was a very challenging exercise because I came at the tail end. So my first interaction with the AG office was on the 10th of August, where they were expected to finish on the 30th or 31st of August. There was an issue of material misstatements. 2 days before we received the final audit outcomes, there were 4 material misstatements which could have led to us receiving a qualification. And I then said, it can't happen under my watch that the department has received unqualified for 9 years. Then on the 10th year, we will receive a qualification. So those issues were immovable tangible assets, meaning work in progress in infrastructure. We managed to deal with that because the following day, everybody was called to Centurion with myself to deal with these issues until late hours. The one issue that was a big problem was the issue of payables and receivables. In simple language, we are talking about the confirmed balances that we have as NDOH together with provinces. One of our biggest problems was the Cuban program, which we had to deal with it. So as part of the way forward to say, what are we doing to avoid that? I then realized that as CFOs, there's a distance between the CFO and the Cuban program. So what I've done is that I've brought the Cuban program financial management team very close to the CFO's office. And as we speak, they are visiting each and every province where they are auditing each and every file of the students who are in Cuba. And we then issue a formal audit report, which I sign off for the CFO of that particular province and the HODs to deal with the matters, and they have to report to me on the 17th of December. And we are not going to stop at that. We are going to go back to the provinces towards the end of the financial year, where we have to discuss about all these balances, because what the AG does is that as they are auditing us as NDOH national, they then have to confirm with their provincial AGs to say what are the balances that the province are having. So we had that difference. So that matter, it's under control. The one issue that also led us to this, to the unauthorized expenditure was an issue where there was a system issue regarding the conditional grants where there was a double payment. I then also for that, as we speak, we are busy conducting the half-yearly reviews on conditional grants with all our provinces. The team was in Northern Cape for this week. Next week, even myself, we're in Free State dealing with Cuban program and dealing with the half-yearly reviews for conditional grants, so that these balances should not give us a problem. So fortunate enough, the material statements were corrected. Hence, we received the unqualified audit opinion. And we are saying, come the next audits, we'll make sure that these don't happen again. There were issues. The unauthorized expenditure, like I've said, that we incurred this on two programs. It was on program 4, Port Health, where we had to pay overtime for officials for Port Health, meaning that we had an overspending on compensation of employees. But when you look at the overall spending on compensation of employees of the department, we did not overspend, meaning that there is some accounting measure that could have been done to correct that. Unfortunately, this matter was discovered by National Treasury when we were writing the annual report, and it was very late. We're not allowed to correct. The second point is, I said we had it on program 6, where we had an overpayment that went to KZN. And the KZN Treasury, because we have to be refunded by the Treasury, because we transfer money to the Treasury transfer the money to the department. They refunded us in May. So that in it, we have got the money. So for us, we are busy writing to National Treasury to request them to allow us to correct the accounting records and financial statements in dealing with this issue of unauthorized expenditure, because we have got the money, and if you look at compensation of employees itself, overall we did not overspend. So it's a matter of accounting records and understanding amongst ourselves, National Treasury, and AG. There was a question on accruals. Yes, we have got a huge challenge with accruals in the health sector. As we speak, they are over 15 billion rand, but they are a result of medical legal claims. Why? Because some provincial treasuries, for example, Eastern Cape, they don't allow our provincial departments of health to budget for medical legal claims. So meaning that when we get a claim, when a provincial department gets a claims, they have to settle without having a budget for that. And that leads to accruals because some things are not going to be paid for that particular year. But to deal with that problem, we have requested all our provinces to come up with their cost containment measures, which we have got, and we even sort of consolidated at a national point, cost containment measures in trying to deal with the challenge of accruals. And the second thing, we are always engaging, we're always encouraging our provincial departments, together with ourselves, to engage with treasuries to be assisted where possible with additional funding in dealing with these accruals. Hence, when provinces are called by their provincial treasury to bid for budgets and discuss budget issues and so forth, with my permanent appointment in the department, I attend those meetings as the Chief Director for Provincial Support. The issue on procurement and supply chain management, it was raised by the AG. We have got a challenge because we have got a challenge here, and even the acting DG has spoken that there's a new organogram that we are pursuing because within supply chain, we don't have a dedicated unit that deals with contract management. But in terms of the new organogram, we have got that. So we are hoping that the structure will be approved as such, and we are able to focus much on contract management because it's one area where we are finding ourselves in trouble. The last thing I need to deal with, there was a question on the underspending on conditional grants for provinces, where I reflected that provinces were allocated 52.6 billion and they spent 51.2 billion, resulting in underspending of 1.3 billion. So the question was, I must read the breakdown per province of underspending. Eastern Cape underspent by 1.7 million, Free State by 239 million, Gauteng 524 million, KZN 99 or 100 million, if I round it up, Limpopo 229, Mpumalanga 37, is it 1,000? Northern Cape 7 million, Northwest 263 million, and Western Cape 0. But I then indicate that as provinces or in terms of DORA, provinces are allowed to request for rollovers of this unspent money if they are able to demonstrate that these monies were committed, with the exception of grants that deals with compensation of employees. Thank you.
Thank you very much, Acting DG. I'm just checking here that Mr. Mrawane, there was a question about emergency medical services, whether it's functional, and then I don't know whether it, yeah, I think you had allocated to Mr. Mrawane, and then health promotion, whether we're still able to undertake health promotion, including antenatal care. Those are just two which I've seen. Maybe quickly, if either himself or anybody else can just deal with that. Thank you.
Thank you, Mr. Morawani. And then I'll give the answers to some questions about the Cuban numbers.
Okay. Acting DG, thank you very much. Let me respond to the health promotion. I think we've identified a number of services that got impacted upon as we're responding to COVID-19 pandemic. we then have a program called the Continuity of Essential Services Program. So through that program, we do receive updates from Health Information System, and it is clear that while the numbers were slightly affected, but the services continue to be delivered in all services, particularly antenatal clinics as one of the examples. But we do draw out a number of data elements and report on them. And as a matter of fact, we're doing that. We're meeting every Tuesday at 1 o'clock to assess and review that. So we've also said with provinces to make sure that that continuity of care and health system recovery is taken forward through proper planning. And we are coordinating that planning. So just to make sure that no service is left uncovered because of COVID-19 pandemic. And I do report, I can confirm that the data has shown marginal decline, but not really decline of anything less than 60% decline. Thank you very much.
Okay, thank you very much. If I can just quickly give the numbers for the Cubans, because there was a question from Honorable Ismail in the chat. So in terms of the integration of students into the system, into the healthcare system now for doctors, over the past 4 years, so that's the numbers of doctors. The breakdown is a little bit more complicated because it goes back to 1997, but I can give these figures. In the Eastern Cape, the absorption has been 247. In the Free State, 176. Gauteng, 401. KwaZulu-Natal, 663. Limpopo, 313. Mpumalanga, 175. Northern Cape, 358. And Northwest, 105. So the total number has been 3,434 in this period, the numbers of students integrated into the services. There are other more detailed questions, figures around the students over the years since 1997, but I think that would be laborious, and we can rather give the chair a presentation for distribution. Thank you. So, Minister, Honourable Chair, I'm done from our side. Thank you.
Well, I was hoping for somebody to comment on the emergency medical services. You don't have Ravin or somebody from that section? Dr. Crisp?
Yeah, Minister, I'm looking to see who's on the, who would know the specific answer to the question. But from my side, we all of us, Minister, are following what's happening. We have lots of challenges with our emergency medical services. It's a complicated program where we have provincial services, and then there are services that are in the metros in local government, and then they have contracts with private ambulance providers as well. So but in rural areas, which I think is what the question was more about, there are still large parts of the country where there are problems, and we are not able to get adequately. And we had a presentation just yesterday from Professor Eddie Maslanga on challenges with getting to particularly community health centers and clinics for women who are in distress in labor. And we recognized a lot of those and discussed that during that presentation. I think we do know that, especially in rural areas, many of these ambulances don't handle the roads well, they don't last very long, and replacing them is difficult. But I think we'll need to get a more specific report for the honourable members, because I know this has been inadequate. Thank you.
Thank you very much, Honourable Chair. That concludes our responses. Back to you. Thank you.
Thank you, Honourable Minister, and members from the department and the Deputy Minister for the responses. There are two members who want to raise follow-up questions. I'm going to allow them. And the third one, in fact, there are three. The fourth one, the acting DG has already addressed, and we're looking forward to that report being forwarded to the Portfolio Committee from the acting DG on the Cuban Doctor Program. The three members are Honourables Van Staden, Soekers, and Siwela. You can please raise your questions now. Thank you.
Thank you, Honourable Chairperson. I think I've been misunderstood about the 85.5 million. I'm talking about the health fourth quarter expenditure report, which was handed in at Parliament for the 2021 financial year in September this year. And I just want to quote from that report under Program 6, Hospital Systems. I quote, 21.3 billion was spent over 21.2 billion available budget, and overspending of 54.4 million or 0.3%. This is largely attributed to the transfers and subsidies where 20.4 billion was spent against a projection of 20.3 billion. It is reported that 85.5 million from the health facility revitalization grant due to erroneous transfer in error, and provinces have been requested to return the excess money, close quote. So my question is, have these provinces returned this money to the National Department of Health? This is the 85.5 million I was talking about. Thank you, Honourable Chairperson.
Honourable Sukas.
Thank you, Chairperson. I just want to say thank you. I think Dr. Crisp has answered the essence of my question in terms of the vaccination of children and the issue of consent. I will not make it a matter of debate in terms of the competency of children to be able to make that. I will leave that and just make that comment to say. But my question was not answered in terms of is the department planning a COVID mass vaccination campaign of learners in conjunction with the Department of Basic Education, and how much money is being allocated to these programs if they are planned? And then just in closing, Chair, we do not live in an ideal world, and that is true, what Dr. Cripps so well described. However, all children's circumstances, as he also said, is not the same. So you do have children that is within a functional nuclear family. And it is within that context that we need to approach this. The issue about legality and competency of being able to make informed consent or giving informed consent where children are concerned, I am not going to make it a matter of debate, but say that it may be in law and it needs to be looked at. I'm part of the public hearings currently for the Children's Amendment Bill. And the issue of informed consent is an issue that needs to be looked at. So given that, I'm just wanting to frame it in that, and I will take it up in a different setting, Chair. And then lastly, the question on strategic sourcing, I think it was answered in terms of the organizational redesign. So no need to go back to that. I'm sorry, I forgot about that. So just the two in terms of the vaccination. Is the department planning vaccination of children and with the DBE campaigns, and then whether they planning to use schools as vaccine sites, and what is the cost of such campaigns if they have planned it? Thank you, Chair.
Chairperson, thank you and greetings to the colleagues. Chair, just a follow up on the issue of the vacancies that exist in the department. The country is sitting at around 44% of unemployment rate, yet we have got the Department of Health having more than 22,000 unfilled posts. What could be the reason for that? For that, and are there plans in place to fill all those posts, or could be the reason be the noise that is out there that the public service is bloated, and so the Department of Health do not wish to fill those positions? Could that be the reason as well? Thank you, Chair.
Honorable Ismail, I'll allow you that last question that you asked for on the group.
Thank you, Chair. Thank you for the opportunity. I just wanted to do a follow-up on what is the total cost for the 2020-2021 on legal fees and subsequent disciplinary procedures. And can you perhaps provide us this information? What are the breakdown of costs per province? If you don't have it here, I understand, but maybe you could also send it to our chair so that we could have it in writing. Thank you.
Thank you very much for all of those questions, honorable members. Just in picking up on the question on the food poisoning and the food challenges, honorable minister and acting DG, it's been raised now about the patient who passed away, but also we've had the incident of the cool canned goods which were recalled. We've also had the incident of the 3 kids reporting to have died from ingesting noodles. And so generally in terms of our attention to food safety, does the department have a role to play in terms of this? And what would it really be doing to advise and bring an awareness of the importance of food safety, healthy foods, foods which are not expired being sold on the shelves in supermarkets, etc. So what is that program that you're having for this? And then yeah, that's a question from myself. I think we'll allow only those few questions. We're looking forward to those responses. Thank you, Minister.
Thank you very much, Chair. Can I just ask Dr. Crisp that the issue of the food safety, we do have a division both on environmental food safety and also quality control on various aspects of safety of food. I'm not sure if you could just check in the meantime while I deal with two issues which have been raised. If you could find colleagues who are in that area who could give very informed responses in terms of that. Chair, let me just deal with two questions. Firstly, Honorable, I think the question of Honorable Van Staden, acting CFO, will be better placed. I hope he understood which report Honorable Van Staden is referring to. Honorable Sukers, on the schools, the answer is absolutely no. We have no intention to go on a mass vaccination of schools, of children in schools. That's why we have made it very clear that as part of the general opening up of vaccination, now that the Pfizer vaccine is approved for children between 12 and 17 over and above the adults, with the 12 to 17 at this stage as a one-dose cover. So this will be done in our normal vaccination sites, including the mobile sites, the pop-up whenever the teams are out there. But we have no intention at this stage, unless if requested by basic education, they have not made the request. So our intention is to provide this as a part of the all of society vaccination program. So, and with that, in that regard, therefore, I think ourselves and you are not very far apart in as far as, parental guidance. And that's why we have said that our emphasis has been, we prefer that parents and guardians look after the children, bring them to the site for vaccination. But in the event that for some particular circumstances, either if you have an anti-vax kind of a family or parents, if the child on their own can actually assert that, notwithstanding what their parents' approach is, they want to have it, and they, after thorough counseling, they agree that that's what they want to do. The law allows that should happen, but also colleagues have covered, including Deputy Minister, other circumstances which the law provides that avenue. So don't take it that the health department wants to break families by encouraging rebellious minors. Definitely no. So, but definitely no mass. So there's no need for us to even say any financial planning, no, because we are not intending to go to do a mass vaccination at schools. Honorable Suela, in terms of the vacancies, overall, our provinces and health facilities want to fill the vacancies. But the challenge is that, as the acting CFO has indicated, the challenge we're having, it's even where we are, before there is even the reduction as indicated in the MTF period in the next 3 years. Even where we are, our provinces are really at a very difficult situation in terms of the compensation of employees' costs vis-a-vis other, responsibilities such as medicines, equipment, maintenance, all other aspects of the comprehensive quality service. So they are not able to have enough financial capacity to fund. So most of these posts are approved as needed, but are not funded. That's why even with internship, medical internships, we struggle every year because of the question of the posts would be approved, but then it's not funded because the compensation of employees is just exhausted. So that's really the issue. But can I get back to acting DG, firstly with the CFO, acting CFO, and then the issue of the food issues.
Thank you, Minister. So the CFO is on standby to answer that question, and then Mr. Morawani does have the answers on the question about the food. Thank you.
Thank you, Acting DG. Thank you, Minister. The question was around the 85.5 million that we were owed on health facility revived grant by provinces. We were owed by 2 provinces, which was Western Cape for 32.1, and we were owed by KZN 53.4. The entire 85.5 million rand was refunded to NDOH. Thank you.
Okay, thank you very much, Mr. Morawani.
Acting DJ, thank you very much for the opportunity. I will deal with the issue of the food, the 3 babies that are alleged to have died after eating, consuming food, 2-minute noodles. I must say firstly that the issue of food control straddles a number of programs within and outside the department. While the department has the legislative mandate, the actual management monitoring, day-to-day monitoring of food control lies with the local authorities, which is where the services are located. But we do also find ourselves having to work with the trading industry in terms of licensing of products that could be sold and entities that must sell them, as well as the National Consumer Commission, or Consumer Council rather. So the team from Environmental Health Services has been engaged in 24 hours around the clock, from the time that the story was publicized. In fact, the story, it's been a lot bigger than the way we look at it. It does not just talk about Mpumalanga. It talks about a number of areas where we need to take care of. So what the team has found today, it's fairly inconclusive. The way of linking the food with the passing away of these children. So the team is still hard at work now. Both the National Consumer Council, the Department of Health, Environmental Health Services, Municipal Health Services, and the Provincial Department of Health of the affected provinces. So rather than issue an inconclusive statement now about what is the real cost, we then do not want to advise the minister on issuing a statement when we don't really know exactly what is the cost. The samples were taken, and the samples were taken, the laboratory tests are not pointing at any direction of a direct poisoning as a result of consumption of those food products. So we therefore do not want to provide that report out at the same time, while we're still investigating. But the matter of food control generally, we are hard at work. In fact, as a department, internally in the department, there are 3 components that are dealing with food control. As a Directorate Food Control, which is responsible for licensing registration of food as consumable products that are sold in the supermarkets or in a variety of outlets in the country. We have nutrition that is responsible for the nutritional aspect of that food that gets sold. We then have environmental health that then deals with the suitability of selling of those products to the members of the public. And these three components are working closely together to make sure that we don't allow anything to slip through the fingers. But the fundamental problems comes with the actual licensing of the informal trader, which is where the problem is, because this then may lie more at the level of local authority. And I'm not actually throwing them under the bus or casting aspersions on them, but I'm just saying it's an area where health as a department has got no direct control. But because we're working together, we want to make sure that when we come to licensing on our part, we have done our work. But the team that's meeting currently is delving into those issues. And as soon as the results are very conclusive, we should be able to communicate them to the members of the public. Thank you very much, Acting DG.
Thank you very much. Minister, back to you.
Thank you very much, Honourable Chair. The question from Honourable Ismail on total costs, legal services, including in provinces, as she said, I think it's better done in a written form because the team will have to get the figures. If with your permission, Ms. Rennie and the team on corporate service could pull the information together and make it available on a written form. Thank you, and back to you, Honourable Chair.
Thank you very much, Minister, Deputy Minister, Department. Firstly, for your presentation. Secondly, for all of your responses. And thirdly, for your promises to send some written responses to the Portfolio Committee. We're looking forward to those. We appreciate all of the efforts which you've made during the period that we've had these waves with COVID. We are mindful that the most important asset of any person is his or her health, and that there are many millions of people who are dependent on the department overcoming, and I've got this in inverted commas, the rough times, and again in inverted commas, the bad time, as expressed by the acting DG. And we're looking forward to improvement in the functionality of the department. And of course, that would, as a follow-up or follow-through, be an improvement in the service provided to the people of South Africa in terms of their health space. And then, very lastly, from myself, we've had presentations from the entities, Minister, and there's one in particular that really stood out for me, and that's the one of the ex-mine workers. So I'm expressing a hope that you will be supporting you and the department, the MBOD and the CCOD on the ex-mine worker program, which I think they're running out as a pilot in the Eastern Cape. But thank you very much once again for coming. We will excuse all of you from our meeting. We had decided earlier this morning that the committee would stay behind. And I'm hoping that those who are not members of the committee would please then leave our platform. Any last words from you, Minister?
Just to thank you, Chair, Honourable Chair, and Honourable members for always giving us this opportunity. We are indeed very happy to be held accountable, and we value this opportunity to present and get feedback from the members. Thank you very much. Chair, you are muted.
Thank you very much, Minister. Honourable members, please stay on the platform so that we can talk about the rest of our work from this moment onwards.
Thank you. Goodbye.
Thank you. Bye. Ms. Majalamba, it'd be helpful if you can also assist me. I'm trying to look at the participants here to see when we are able to continue with our discussions.
There are still guests in the platform, Chair.
Can we please ask our guests to leave us for us to have a little meeting, a discussion? Thank you.
Chairperson, sorry, and what about the media people? Are they also not supposed to leave us?
I think that is, yes, I think that is.
I can see ENCA here. So it's better for them also to leave because they will report some other things that are not supposed to.
I am not certain in terms of the rules what the next plan ought to be. Can we not ask these media channels just to do the good thing and please leave this platform so that we can have our internal discussions?
Sorry, Chair. Yes, the rules do allow for a closed meeting if the committee decides to have a closed session. We can remove them if they are not exiting the platform.
Okay, I'm going to make a last request to the Parliament YouTube streaming and to the ENCA media group to please leave our platform. Be so kind to please do this and then save us from having to remove you from this meeting, since we have had a majority of members requesting a closed meeting, which is allowed in terms of our rules. You can remove them, Ms. Majalamba. Thank you very much.